Welcome everybody, and thank you very much for attending what is the 5th annual conference for the Collaboration for Compassion in Healthcare Education. So I said good morning and good afternoon to those who are joining us from elsewhere in the world, and certainly from across the UK and Ireland. My name's Sarah Tobin. I'm a lecturer here at the University of Plymouth in the Faculty of Health, and I'm one of the panel, and I'm just going to hand across to my co-panelists who will introduce themselves. So,
all right, my name is Tosin Imade, but you can call me Tosin. I'm excited to be here as a first-time panel member to this meaningful conference. I'm a final year mental health nursing student at the University of Plymouth here, and with a great or a kind of strong dedication to patient-centered care and addressing health inequalities. I have a background in public health, and I understand that as a nurse to be, I'm required to be prepared and engage with research. And over the years, I've gained a kind of meaningful experience working with multidisciplinary team in healthcare settings, including public health. And this experience has solidified a kind of passion for me to foster compassionate care. And this is why I'm here. So today, I'm happy to contribute to this meaningful conversation and collaborate with everyone here. So again, I would like to thank the team for approving my expression of interest. Thank you.
Hi, my name's Riya. I'm a 5th year dental student and I'm very excited to be here as well.
Thank you. My name's Nick Perez. I'm absolutely delighted to be here. Attended all of them last year, and they really are very positive and I think really grounding experience. It's actually the highlight, I think, for me on the conference circuit every year. So by day, I'm the Director of Digital Innovation and Transformation at Tobin South Devon NHS Foundation Trust. I'm also a research fellow here at the university. My kind of interest and domain is very much in digital healthcare. My PhD was on compassion and medical simulation and using technologies like virtual reality in education as well. Very passionate about the patient experience and perspective, and that's where really a lot of my practical work lies. I'm also the National Advisor for NHS England on new technology in healthcare, and again, really looking at technology from a very human perspective. So again, delighted to be here. Thank you.
thank you very much to the panel. I think compassion is an incredibly important subject always, but perhaps never more important than just at the moment. We seem to be in a world that is full of challenge and confusion. I turn on the news each day with trepidation and fear, and often, sadly, that is realised as a reasonable approach. And we're told that the health service that many of us work in is on its knees. But I've been researching in compassion for a time now, and I've worked out that compassion, a bit like love, is always stronger. No matter what we're told about the parlous state of the country, the health service, the department we work in, the area we work, the ward we go to, it's our choice how we want to see that. And I choose to see the compassion that is there every single day in every area that we work in. For every awful thing, there's the response, which is always a compassionate response. And I believe that for us as educators and for those of us who are clinicians, that compassion is not just a humane thing to do in our practice. I think it's a really important element to provide clinically relevant and effective care. And it's not just my thoughts. There's an increasing body of evidence that suggests and demonstrates that compassion enables us to provide clinically very relevant healthcare. Recently, I was teaching on a course, and a community matron came to see me after the presentation I'd given about compassion in healthcare and said that for years she'd been told she was too kind. Now, there's an oxymoron, if ever I've heard one. But what we can now do is have the vocabulary to explain that we're not too kind, that we're clinically relevant, and that our kindness is an important element of our clinical care. Care with compassion ensures that we align our priorities with that of the patient. And if we don't do that, care often is stilted or even incorrect. We risk harm much more if we don't align our priorities. Patients will tell us what we need to know if we formed a relationship with them that they believe results in trust and care. It increases concordance, and with increased concordance comes better outcomes for patients. It decreases the use of resources, which is really important at the moment. And by decreasing the use of resources, I mean that people are evidentially discharged quicker in places where they're treated with kindness and compassion. They take up less medication. There was a study that showed significant reduction in analgesia use in patients who felt they were treated with kindness and compassion. There was a study that showed that patients, so-called revolving door patients, which is a really awful term, but reduced their attendance back in EDs when they were treated simply with kindness and respect. 30-odd% reduction in reattendance, which is a massive win for if people can't think of doing care with compassion because that's part of them, then do it because it's economically the most viable way of treating patients. So it's not an option, it's a clinical imperative. And this conference will, I hope, highlight work that's being done, initiatives that are being put into place, teaching protocols that people are using, and will hopefully open your eyes to some of the passionate work that's being done across the country. And this is a hybrid conference. For the first time, all our other conferences have been entirely online. We started during COVID, a time when compassion and the need for compassion was so very relevant. And for the first 4 years, we carried on as an online only event. But today we also have some people live in our audience with us, and I'm delighted to see them. So forgive us as well if there are occasional glitches because we're trying to manage an online audience and an in-person audience, but hopefully that will add, not detract. We're using Slido. So for those of you who are joining us online, if you have any questions of any of our panelists or of us, please just visit Slido. The little link is on the screen right now, and you put in that code 1880416 and ask your question. We as the panel will see the questions. If you like a question, feel free to like it, and that means it will be promoted higher up the list of questions asked, so we will know which are the most relevant questions to ask our esteemed panelists. And also through this day, we have 2 opportunities to do separate elements within this conference. The first is a lunchtime workshop. And when you were sent the link, for those of you who are online, you would have been sent the link to join a separate Zoom to come to the lunchtime writing workshop. And I cannot recommend that enough. Dr. Roshni Behari is a brilliant exponent of writing for wellbeing. And we're really privileged that she's provided workshops at several of our conferences, and they have always had extremely positive feedback. And Roshni is a delight to have in our conference. So hopefully you'll support that. For those of you who are here live, we've got a classroom upstairs that you can go up, so you can also take part in the writing workshop. And then in the afternoon, we have a Schwartz Centre round that is running for the University of Plymouth, and there's a separate online link to join the Schwartz Centre round as well. But I'll remind you of that as we go through the conference. I'm going to finish now. Again, I'm delighted that you've come to this conference. We are going to be recording it, so if you miss any bits of it or can only attend for certain parts, the recording will be put onto the Collaboration for Compassion in Healthcare Education website, where the previous 4 conferences are all available for free to watch at your leisure. Any of you who are educationalists, there's some brilliant sessions. I use them constantly in my teaching. Feel free to mine them as much as you want to for any content that would be helpful in your teaching endeavours. And if you're a student, there's some cracking stuff there to go back and listen to. So I'm going to hand over to our first speaker now. Our speaker is someone who we are delighted to say has become a bit of a patron of the Collaboration for Compassion in Healthcare Education. Professor Michael West has spoken at every one of our conferences, and I would say without fear of exaggeration that Michael is one of the greatest exponents of compassion in healthcare, and especially compassion in healthcare education in this country. Michael's a senior visiting fellow at the King's Fund in London and a professor of organisational psychology at Lancaster University. He's also a visiting professor at University College Dublin and an emeritus professor at Aston. He graduated from university some years ago, I'm not going to say when, and 4 years later was awarded his PhD for research on the psychology of meditation. He's authored, edited and co-edited 20 books and has published more than 200 articles in scientific and practitioner publications. He's a fellow of the British Psychology Society, the American Psychology Association, and the Society for Industrial and Organisational Psychology, as well as a number of other august organisations. To be honest, if it's important, Michael's got a finger in the pie. Including as an honorary fellow of the Royal College of Physicians and Surgeons of Glasgow, a fellow of the Royal College of Surgeons of Ireland, and the Faculty of Nursing and Midwifery. He led the English Department of Health Policy Research Programmes into Cultures of Quality and Safety. He also led the NHS National Safety Staff Survey and assisted in the development of the National Framework on Improvement and Leadership Development in England. He supported Health Education and Improvement Wales to develop the National Health and Care Compassionate Leadership Strategy in Wales. He co-chaired the Dame Denise Coyer 2-year inquiry on behalf of the UK General Medical Council into mental health and well-being of doctors in a document called Caring for Doctors, Caring for Patients. He led the review for the King's Fund, commissioned by the Royal College of Nursing, into the mental health and well-being of nurses and midwives across the UK in a document entitled The Courage of Compassion. Is supporting nurses and midwives to deliver high quality care. His latest book, which is an absolute cracker, I tell you, came out in 2021 and is called Compassionate Leadership, Sustaining Wisdom, Humanity and Presence in Health and Social Care. And get it, there's just no argument not to be honest. And he was appointed, quite rightly, a CBE in the Queen's Birthday Honours List in 2020 for services to compassion and innovation in healthcare. And it is my absolute delight and privilege to hand over to him now.
Well, thank you very much, Sarah, for that very warm and generous introduction. I think my mother must have written that introduction for you. I was reflecting on your introduction, and it reminded me of a book I read last year by Rebecca Solnit. She's an amazing writer, feminist, activist. The book was called Hope in the Dark. And she describes in the book how hope comes not from some starry-eyed optimism, but from us taking collective action together to bring about change. And the work that Sarah, you and your team are doing at the University of Plymouth is a wonderful example of collective action that gives us hope in the dark. And it is through collective action that we need to bring about change in our healthcare systems, which are, after all, maybe the anchor, the heart of our societies, because they constitute the largest workforce and they touch the lives of every human being in our countries. So taking action locally, nationally, globally is of fundamental importance. And I want to just briefly talk about some of the initiatives that really are there that can give us all hope from local to global levels. And I want to begin by really talking about the initiatives that we individually can take locally, because in a way, the most powerful action we can take is the actions and the interactions we have every day. Every interaction we have is an opportunity to shape the culture of our workplaces, of our societies, through how warm, irritable, cynical, kind, humorous, aggressive, compassionate we are. We know that the emotional and behavioral ripples spread out through at least 3 degrees of separation. So individually, we can make a huge difference. And the work that I've had the privilege of being involved in with so many people in health services in the United Kingdom and further afield reinforces that compassionate leadership is something we can all take responsibility for. It's also about recognizing that compassionate leadership is not simply about attending, being present with each other, understanding each other's challenges, empathizing and helping. It's also ensuring that we're creating the conditions where people are clear about what it is they're required to do in the workplace. Our teams are clear, they have direction, and that we're aligning people's efforts around that direction rather than wasting them unnecessarily. It's creating environments where collective leadership thrives. We know that from the international research that about the worst kind of environment for healthcare is target-driven command and control environments. Last week I was in Esbjerg Hospital in Denmark, where there are only 3 hierarchical levels. There's a very small executive team, 4 people. Then there's 40 people who provide management, and then after that, it's just frontline teams with team leaders. So a hospital of 4,500 people with 3 levels, and that's not unusual in Denmark. We can do this. We can move towards more collective leadership where we release the pent-up innovation of this most highly skilled, most motivated, and the largest workforce in our country, those who work in healthcare. It's establishing cultures where people learn and reflect and develop new and improved ways of doing things rather than cultures of fear and blame, which dominate many of our healthcare organizations. It's moving towards leadership that is compassionate. Compassion's about moving towards pain. So it's managing difficulties, difficult behaviors, conflicts in a very open, transparent, courageous, wise way. It's developing supportive team working. So, I think that we must recognize that healthcare is delivered by teams, and it's teams we need to manage, not this rather myopic focus on managing individuals and dyadic relationships. It's empowering teams to be effective, and it's recognizing that teamwork is as much about how we work with other teams as how we work within our own teams. And compassionate leadership at local level, at individual level, is, of course, improving equality, inclusion, and diversity. If leadership is not inclusive, then by definition, it's not compassionate. And if it's not compassionate, then by definition, it's not inclusive. And it's so fundamental for us to change the cultures of our organizations so that they are inclusive of everybody feeling at least equally valued, respected, and supported, all voices listened to. And it's enabling safe, respectful, trusting, and engaging environments. So it's not only about creating environments where we feel psychologically safe, free from threat, but also where we create safeness, as Paul Gilbert says, environments that are caring and warm and nurturing. And individually, it's about focusing on how we better meet the core human needs of colleagues. We can so easily forget that we are animals. We have core needs as human beings, and that we have to meet those needs of those in our workplaces if they're not to become stressed and burn out and demotivated. And that's meeting their needs for autonomy and control, so people have voice and influence. They work in cultures of justice and fairness. They have basically reasonable working conditions and influence over shifts and rotas. That we build that need, we meet the need to belong through building effective team working and compassionate cultures. We meet the need for people to be effective and to feel a sense of contribution and competence through addressing the issue of chronic work overload, the number one predictor of staff stress and quitting, and that we provide regular, supportive supervision and coaching and management for staff so that they feel valued, respected, and supported, and that we give people opportunities for continuing learning, development, and growth. It's a key factor in staff retention. At organizational level, the kind of initiatives we're seeing are extraordinary. I spent some time with amazing clinical psychologist, Dr. Deborah Lee, a close co-worker of Professor Paul Gilbert last week in Denmark. And Deborah was describing how in Berkshire Health they've been retraining all of their leaders and now all of their staff in compassionate leadership for the last 6 years. And they have the lowest levels of staff stress, the highest levels of staff engagement of any organisation in the NHS now. And they're rated outstanding by the Care Quality Commission. I described briefly the structure in Denmark, where they have also within that organisation a compassion team that's developing compassion across the entire organisation. Shifting the cultures of our organisations to compassion is critical, and I've had the privilege of being involved with the King's Fund, NHS organisations, 3 NHS trusts and the Centre for Creative Leadership over the last 6 to 8 years, focused on how we create or strengthen the key elements that enable us to have compassionate, inclusive and collective cultures. Organisations which have a really clear, inspiring vision and set of values that aren't just a bunch of words on the website, but are part of the genetic structure, the DNA of those organisations, where there are clear goals at every level, 5 or 6 clear, agreed, challenging goals, not 56. Where there are cultures of learning and innovation, support and compassion, equity and inclusion, and team working, as I've said. And we've designed a programme with NHS trusts and NHS England over the last, 8 or 9 years now, making the links between the cultural elements that I've described, the associated leadership behaviours, and the outcomes that we seek. So we see, for example, that where you have clear vision and values, that translates into facilitating shared programs and for the way we do things around here, which translates into quality of care and value. We know that having clear goals and performance is associated with much better outcomes, support and compassion. As Sarah was saying, the evidence is now overwhelming that compassion is the most important intervention we have available to us in healthcare. Recovery is much quicker, adherence to medical protocols and treatment protocols is much better. Life is, people's lives are longer when they receive compassionate care. And we know there are huge benefits for caregivers in randomized controlled trials with GPs and nurses asked to be extra compassionate in their interactions with patients over a 2-week period. That has a significant impact on their own well-being with lower levels of anxiety, stress and depression. So compassion is fundamental. And as I've said, equity and inclusion are vital. We know that the more we have cultures of equity and inclusion and value and diversity, there is better then care quality for patients in those trusts and better financial performance. And we know that the reason is that patients treated in hospitals with cultures of equity and inclusion receive treatment which is more compassionate and characterized by greater civility, resulting in better care quality and better financial outcomes. And the role of team working is fundamental. To make these organizational changes, it's critical that we make sure that we're using the scientific evidence to persuade policymakers and leaders of the need to transform our cultures. Target-driven hierarchical cultures simply do not work, but transforming cultures to strengthen these key cultural elements that I've described is critical. And we can demonstrate for each of these key cultural elements the improved patient and financial outcomes which result. And there are something like 80 trusts that have now gone through this program, and the program's been independently evaluated by colleagues in different universities. And the latest evaluation shows that trusts that go through this program have afterwards better patient satisfaction, better care quality, better leadership, better financial performance. And so the evidence is kind of incontrovertible. Isle of Wight Trust was, I think, rated inadequate or requiring improvement when Maggie Oldham joined as the new chief executive and implemented this culture and leadership program. And within 3 years, they were rated as good. The program has a huge range of tools, and all of them are available open source on the website. One example of these tools is compassion-based recruitment. Each of the, I think it's 40 or so tools, has content. What is this compassion-based recruitment? Why is it important? What's the research evidence? And how is it done? With case studies to support the implementation. There are so many initiatives going on at organizational level around the country, people collectively creating hope through transforming cultures to enable them to be more compassionate and inclusive and collective. At national level, one of the great examples is the work going on in Wales, where the compassionate leadership principles are informing an overarching strategy to ensure that by 2030, leaders in all of health and social care in Wales will display collective and compassionate leadership. Recently, the Director General of the NHS in Wales wrote to all of the chief executives insisting that they model the compassionate and inclusive and collective leadership which is advocated at national level in Wales, rather than modeling behaviours that are aggressive or undermining or difficult. Aligned to the principles, Wales has launched a compassionate leadership pledge that national bodies like Health, Education and Improvement Wales have signed up to, where they commit to pursuing, promoting, developing and embedding compassionate leadership principles across the system. And I think over half of the NHS trusts and boards in Wales have now signed this pledge, with the others already committed to signing them as well. And that pledge is available internationally now. Wales is taking this initiative even further. It's not only about developing compassionate leadership, but implementing compassionate cultures. The staff survey has measures of compassionate leadership and compassionate culture. It's about developing compassionate team working. And again, the materials, the resources being developed in Wales, they're very keen to share with people across healthcare systems, not just in the UK, but around the world. A lot of focus on also compassionate policies. And my feeling is that focusing on how we influence policy now collectively has to be a priority for our work on developing compassion in healthcare. And as I say, in Wales, they've developed a huge range of resources to support the development of these cultures, not only in relation to compassionate leadership, but clinical leadership, creating diverse talent pipelines through succession planning and talent management. And a lot of these materials are available on the Gwella website. If you type in to your search engine, HEIW leadership portal Gwella, then you'll get access to the Compassion Hub. So there's lots of reason to hope. And globally, we're facing huge challenges in healthcare. The World Health Organization estimates that within 6 years, the world will need at least 40 million more healthcare staff. The Global Compassion Coalition, of which I'm a part, is focused on how we develop compassion more globally, to build a world where compassionate intentions and the courage they bring are at the heart of our political systems, our economic systems, and of course, our healthcare systems. And I and many others are now involved in nurturing that focus on healthcare within the Global Compassion Coalition, and we're always eager to have colleagues join us. One of the initiatives we've undertaken is to build a coalition of nations to focus on how we influence practice and policy in healthcare systems across nations, so that across the 4 UK nations and the Republic of Ireland and Denmark and Netherlands and now many other countries around the world, we want to create social support for those working in healthcare to build compassionate cultures. We want to ensure that we're sharing the resources with each other that enable us to pursue that vision effectively. And we want to ensure that we are influencing policy together. So working together to find ways of influencing policy in our various countries and collectively. The Global Compassion Coalition was launched in terms of a membership drive last year in June. It now has over 130,000 global members, with more than half of them from the global south. And you can learn about the work of the Global Compassion Coalition by going to the website globalcompassioncoalition.org. But I want to finish by emphasizing the huge importance of what we mean by compassion in society and in our healthcare systems particularly, and to share with you a video that's been made by colleagues in Wales that I think kind of sums this up beautifully.
important. So thank you for that.
Thank you.
I think we have got to the point where we have unfortunately run out of time. I've got 1,000 questions that I want to ask you, and I know that's the same for those out there, but that's one of the joys, but also one of the challenges of a conference, and we do have to move on. People are writing in the chat, thank you, and I will offer mine as well for that. As ever, thank you so much for joining us and for sharing your wisdom and your thoughts about not just what's going on locally, but what's going on nationally and indeed globally. So thank you for that, Michael, and hopefully you'll be able to stay for some of the other talks, but if not, we'll see the recording. But thank you so much. Good to see you. And I'm going to hand over to one of my colleagues who's going to introduce our next speaker.
Hi, so I'm going to introduce Helen Francis-Wenger. To my delight. Helen's nursing career began in Essex, England, specialising in emergency medicine. After moving to Cornwall in 2013, she progressed through the roles including lead nurse and clinical practice educator in emergency medicine secondary care. Since 2014, as an advanced clinical practitioner in emergency medicine, Helen shifted her focus to postgraduate education, becoming a lecturer in advanced clinical practice at the University of Plymouth, and now a senior fellow of the Higher Education Academy. She contributes to the Centre of Advancing Practice and the supported e-portfolio route, supporting practitioners in earning their digital badge. Helen is the Deputy Chair of the Association of Advanced Practice Educators and has a keen focus on delivering a high-quality education within the sphere of advanced practice, showing best practice on this and how it translates from the learning environment to the various clinical environments the advanced practitioner works in. Part of this is an interest in supporting supervisors in the workplace to ensure adequate and robust clinical supervision across the disciplines. Helen.
Very much. So, what a introduction, and how to follow Michael after that. That was inspiring. So this is a short synopsis of a piece of work that I undertook in 2018, and it is solely focused on one emergency department. And I appreciate Michael was talking about the global impact of compassion. This is honing it right down into one emergency department in the southwest of England. And it was undertaken when I was in the role of a clinical educator. And in that role, I was faced with all nursing staff and addressing their educational needs. But it became apparent on the basis of exit interviews and the attrition rates that we were experiencing at the time that compassion fatigue was anecdotally a contributing factor to the low morale that was being experienced in the department. So emergency department work has always been challenging but fulfilling. Many people think it's like Marmite, you either love it or you don't. But operational pressures that are being experienced at the minute, as well as the pandemic, have intensified the challenges that are being experienced. One of those challenges is something called exit block. An exit block is defined as a concept of a patient's journey through the emergency department is hampered for some reason. And that means that they can't get into hospital wards, they can't transfer to the wards, they can't be discharged home with support. So the patients are ending up spending a lot longer in the department than they should be. And that puts additional stress and strain on the staff and on the system because new patients can't get into the department, as we've all seen many ambulances parked up outside EDs. And that puts an added pressure that no one was ever expecting to have to deal with. And so it just to put some numbers to that, in 2017, 500,000 patients a year were affected by exit block. And in 2022, so 5 years later, 1.6 million people. Now, if that's our patient's experience, we have to think about the staff's experience of that as well. And in 2021, the Royal College of Emergency Medicine did a survey, so post-pandemic, and found that 3 out of 5 emergency medicine staff said that they'd been experiencing high levels of burnout, stress and exhaustion. And 70% of those respondents said that patient care and patient safety was being affected because of that. Now, the reason for this study was that exposure to trauma, distress, frustration, violence, resuscitation, patient deaths can all be negative aspects of healthcare professionals' roles. And being exposed to those elevated levels of human suffering often come with little or no opportunity for self-care or emotional decompression. So some of the terms that you may have heard banded around became the focus of this study. And in 2010, STAM states that healthcare staff working in challenging situations with direct contact to patients and those in need can affect compassion levels in a positive way, compassion satisfaction, and in a negative way, compassion fatigue. The challenging situations that place a significant demand on compassion satisfaction levels of ED staff can cause them to end up with inner conflict manifesting as compassion fatigue. So it's important to be aware of these terms, and you can see that the four main bullet points there: providing care to patients, working in a system, working with colleagues, and personal self-beliefs all can have a positive and a negative impact on staff's mental and physical well-being. Under the umbrella of compassion fatigue is the concept of burnout and secondary traumatic stress. And these are co-travelers, and they work together hand in hand, like I say, under that umbrella of compassion fatigue. And regular exposure to stressful life events of others can precipitate nurses' increased indifference and reduced empathy to under that umbrella of compassion fatigue. And it can be conceptualized as emotional, moral, or physical distress as a result of being witness to the suffering of others. So we took those sort of definitions, I took these definitions and made them into this project. So the overall aims were designed to explore and understand what leads ED staff to feel stress and burnout and the consequence reduced compassion satisfaction whilst delivering patient care. And the objectives were to assess the prevalence and severity of compassion satisfaction and fatigue, to gain understanding of the nurse's perception of compassion satisfaction and fatigue, to explore those aspects using a validated tool, the ProQual5, which I'll talk about in a minute, and then potentially to identify any further areas in need of study to help improve compassion satisfaction level or reduce compassion fatigue. So the overall literature, the overall process of it was a literature review was conducted in 2018. It was then revisited in 2022 with a post-pandemic slant. And three main themes came through from the literature: intervention and support for staff, work environments and workload, and patient focus. Then we moved on to the methods section, and this was a mixed method study. So the first phase was a quantitative phase using this validated tool, the ProQual5 questionnaire. And the results from that ProQual5 were moved into and influenced the second phase, the qualitative phase, whereby semi-structured in-depth interviews were conducted. So just a bit more detail on the literature review. In 2018, the literature review found 14 articles eventually that were eligible for inclusion, and the themes were there. So intervention and support, this was all about what support can we provide for staff? What interventions could we implement? And this was about building resilience. Now, resilience is an interesting word. It's very difficult to define. It's very difficult to quantify. But the literature was really focused around how. How do we do this? How do we make this individualized for the staff involved? And it included discussions around educational strategies, and we're going to talk about some of those later, I believe, including things like written exposure therapies, mindfulness, gym memberships, counselling therapies, all those additional elements that could promote strength and resilience. The second theme from the literature was work environments and workload, and this considered the effects of work-based stressors, emotional stressors, job satisfaction and kindness that people were experiencing within their workplace. And the third aspect was patient focus. And as Michael alluded to, the inability to complete patient care or tasks increased frustration and cynicism and subsequent compassion satisfaction levels. So you can see these are all really complex phenomena that are intertwined and interwoven together, and they're really difficult then to untangle and fully explore. One of the things, I've got 2018 versus 2022 there. One of the things, the literature review was revisited. So the difference between the two was that in 2018, the literature focused around secondary care settings as a whole. In 2022, when we revisited it, there was a much more, there was a much bigger quantity of articles focused on high intensity settings, so EDs, ITUs, that sort of place. So it was really interesting to see that that gap in the literature had been addressed. So when we got to it in 2022, it demonstrated that exponential rise in the volume of work, and even when the search term was reduced just to a 2-year period, the 2020 to 2022 period, it still resulted in a significant volume, in fact 64 articles, when compared to the same single search term of resilience and burnout in emergency nursing. In the 2-year period 2016 to 2018, there were only 22 articles. So we've gone from 22 to 64 relevant articles focused on high intensity areas of nursing. And at this point, I'll just say this study was focused on nurses. Okay, if I were to revisit this study and do it again, I'd make sure it included all staff working in the emergency department. But for the focus of this master's level study, it was just looking at nurses and experienced nurses as well. So nurses that had been employed for 6 months or more and had been qualified for over a year. For the inclusion for phase 2, the plan was to have between 2 and 5 staff who scored high, moderate and low on the compassion satisfaction scale from the ProQual 5. So that was our inclusion criteria for the second phase. So the overview of it, like I say, it was one trust that this was looked at, and an explanatory sequential mixed method approach was adopted, and it comprised of 2 phases. The first phase, as I said, the quantitative phase, we used the ProQual 5 questionnaire to obtain information on the prevalence and severity of compassion satisfaction and fatigue, the phenomenon. The results from that then influenced phase 2, in which a qualitative approach was applied to explore the participants' perceptions and experience of compassion satisfaction and fatigue in depth. And the aim was to identify the extent of which the concepts affected them, any mitigations that they had put in place for themselves, and to identify the areas in need of additional study. So the ProQual questionnaire is a fabulous resource. It's not the only one, so I'm not here just advertising that. It's really good because it's free as well, and it provides a really good explanation as to the results that people come up with. It's been in existence for 15 years or so, and it's a 30-point questionnaire, a self-report measure, and it measures both positive and negative aspects. And it arrives at 3 scores. It gives you 3 scores. One of those scores is for compassion satisfaction, that green box, and the other 2 scores are for burnout and secondary traumatic stress, and they come under that umbrella of compassion fatigue. Throughout all of this, though, I made it very clear that this is not a psychological test. This is not a medical test. It's a screening tool, and a screening tool for stress-related health problems. And as I said, the aim was to understand the negative and positive aspects of those, helping people who experience trauma and suffering, because it's about keeping a balance, and it's about understanding people's own ability to keep that balance. On to phase 2 then, the plan was that the compassion satisfaction score that people arrived at from their ProQual questionnaire became the focus. And from that, 2 respondents scoring highest, 2 respondents scoring moderate, and 2 respondents scoring in the low category for compassion satisfaction were invited to interview by myself, and the interviews lasted an hour. They were recorded and transcribed verbatim. The semi-structured focused interview used a topic guide, and that topic guide came from some of the statements in the ProQual questionnaire. And that meant that the language was familiar to the participants, so that there was nothing that sort of caught them off guard. And the interviews happened away from work and when they were not on shift, because that was felt that could have influenced the responses that we might have got. We also offered, I offered the participants the opportunity to explore the relevant areas of the ProQual that they felt hadn't been identified. So they had that opportunity to add in anything else that they thought was relevant. So the results, 58 staff were eligible for the inclusion criteria, and 44 responded. So that yielded a 76% response rate, which I thought was quite good. Of those, 14% had a high compassion satisfaction score, and 86 had a moderate compassion satisfaction score, which I was quite surprised at, but it's good. That's a good thing. And the most interesting thing from this phase was that nobody had come up in the low category for compassion satisfaction. So we analysed that, and it probably indicates that they derive a good deal of professional satisfaction from their position and being able to do their job well. However, to move on to phase 2, we had to adapt the moderate and the low compassion scale so that we could get a range of participants for interview that had the highest and the lowest score for compassion satisfaction. So with our new adapted compassion satisfaction scale, we moved on to phase 2. And here, so we interviewed 6 people. And from thematic analysis, incorporating a hermeneutic cycle, we became immersed in the data. This is a process that allows for continual movement between the parts and the whole of the text being analysed. And that led us to understanding, reaching that understanding. We considered the Hawthorne effect. The Hawthorne effect is an interesting concept. People change their behaviours when they know they're being studied. So we took that into consideration. And 3 main themes came out from that thematic analysis. So we had personal reflections, factors identified as maintaining stability, and factors affecting compassion. So those themes had sub-themes, and you can see that the personal reflections were the personal insights whereby people saw both positive and negative effects from having standards, having personal relationships. They had their own personal coping mechanisms, they had control, they had a patient focus. And when those things went well, they felt more satisfied in their job. So they had greater compassion satisfaction. When they were jeopardized for some reason, that's when issues crept in and the feeling of reward wasn't there. Factors identified as maintaining stability was about their ability to keep themselves sane, for want of a better word, so to hold on to their stability. So this was their desire to help. People were doing the job because they want to do the job, and that's what everybody in healthcare is there for, because they want to do the job. So they've got that desire to help. They enjoy caring, they have resilience, they have that ability to detach from their work from their home life. And again, all of these are things that can be jeopardized for varying reasons, if things are going on at home, etc., etc. And so if that stability is jeopardized, then we run the risk of decreasing compassion satisfaction. And then the interesting external factors, this was the bit that took up a majority of the interview time, whereby people had opinions on external factors that affected how they could deliver the care to their patients. And these were things like departmental politics, departmental management, national targets. As Michael said, targets do not promote good quality patient care, although that was their original intention when they were implemented. So it's all of these things are external factors that had an impact on the participants of the study. And a few quotes from them. I won't read them all out, but I'll leave them there for you. But this is how we arrived at those themes of personal reflections, the maintaining stability, and the external factors. And you can see that these are obviously open to interpretation, but it's clear that when asked directly how individual staff were affected by the work, this is some of the themes. These are some of the themes coming through. So finishing off the study, no respondents in phase 1 had high levels of compassion fatigue, and that was a really important finding. Yet when we moved into phase 2, it demonstrated that the ProQual 5 questionnaire on its own was insufficient to explore this complex subject. So although the prevalence of burnout and secondary traumatic stress was low to moderate in this study, this has got the potential to change if repeated pressures keep affecting the delivery of care. And this is an overall important topic because work-related stress is a major cause of sickness absence in the health and social care setting, with 2.9 million working days a year lost to work-related stress. That was last year's figures. So the findings of the study don't reflect that the potential manifestation of this risk. Okay, so we were expecting to identify it, but it didn't demonstrate that manifestation. But the warnings of this need to be heeded, particularly in the light of the COVID pandemic and the ongoing operational pressures that we're experiencing in the NHS at the moment. So the plan, sorry, just go back, the plan, some of the discussions from the literature and from the comments from people's interviews were that things needed to be implemented in the department. So people recommended the use of a trauma risk management facilitator, a TRIM facilitator. People had recommended the implementation of debriefs, whether they be hot or cold. So hot immediately after a stressful event, and cold allowing for a period of time after the event for reflection and for further details to come forward. And then mechanisms about promoting self-care. In one of in 2022, a study identified, this was during the pandemic, identified that sending motivational messages to emergency nurses found that these they trialed sending motivational messages to emergency nurses, and what they found was that these increased job satisfaction when they surveyed these members of staff. It improved communication, and it reduced compassion fatigue. So it's promoting staff motivation, and it's essential to increase employee satisfaction and ultimately delivering patient care. So the recommendations going forward, I've put back to the trust, were that they undertake regular screening using the ProQual or equivalent to assess the compassion, satisfaction and fatigue for all. Implement debrief sessions, implement resilience training programs and building strategies, and employ a member of staff within the department as a TRIM facilitator. And I'm pleased to say that that has happened, and there is a member of staff that's been trained up as a TRIM facilitator. So that is working well and is accessible by all. So to finish off, compassion is not a commodity or an attribute that can be wholly taught. Okay, it can be. It's a powerful asset that needs. That individuals possess, and it has to be harnessed and nurtured. It has to be facilitated, protected and enabled to allow our staff, our peers, our colleagues, our friends to care for each other and ultimately care for our patients. The findings of this study show that the emergency nurses in one emergency department were not demonstrating signs of compassion fatigue. That's just one emergency department. And although some staff may require additional support to achieve a more stable level of compassion satisfaction. Preventing and assessing and addressing burnout and secondary traumatic stress in the emergency department is a shared responsibility that lies with all ED staff, managers, leaders, and strategic leads, particularly in the context of this post-pandemic era that we're in, as well as the ongoing operational pressures that we are experiencing. So thank you very much. Have we got time for questions or?
I think unfortunately we've run out of time for
Okay.
questions, but thank you so much, Helen.
No
That was a really interesting,
Thank you
really
very
interesting
much.
study there.
On Slido, I think asked quite early on in your talk, and you've covered it brilliantly. So the one major Slido question has already been answered. So thank you very much for that.
Fabulous. Thank you very much.
So again, I would like to thank Helen for that insightful presentation, where she described her findings on that explorative mixed study relating to compassion, satisfactory, and fatigue in emergency nurses. So in a moment, I'll be introducing Maaya Modha-Patel. She's going to be taking us through the next presentation. And Maaya, she's a senior lecturer and a pharmacist and an advocate for creative health and social justice at the Queen Mary's University in London. Maaya has worked in the UK hospitals, retail pharmacies, and university, connecting with patients and the public to provide compassionate, person-centered, and working with pharmacy and medical students to support them with developing an authentic and empathic approach. Maaya, she's passionate about race equity in healthcare, piloted a scholarly project focused on anti-racism in medicine with the third-year medical student last year, while in a post at King's College London. She'll be presenting the research related to this initiative shortly. In addition, shortly after she delivered her first child in 2021, Maaya, she joined the Creative Health Master's course at the University College London and recently completed her self-designed master's research, which she explored the impacts of a 5-week online mindfulness course on the perinatal mental health outcomes of a group of Black women who were pregnant. So outside of academia, she supports clients with their health and fitness as a personal trainer and regularly invited on the BBC Radio London and BBC Asian Network. Over to you, Maaya. Thank you.
Thank you very much for such a lovely introduction. Thank you, everyone. It's lovely to be here. I'm looking forward to sharing some of my research with you. Perfect. So today I'm going to be talking about anti-racism in the future healthcare workforce and embedding compassion as an antidote to racism. So thanks for that lovely introduction. My name is Maaya Modha-Patel. I have a master's in pharmacy, a master's in playwriting and screenwriting, and just completed a master's in creative health. And I'm also a fellow of the Higher Education Academy. My current role is working at Queen Mary University London as a senior lecturer in communication and professional skills, working on the MBBS or medicine course. And the research I'm going to be sharing with you today, it was conducted as part of a role I was in last year, working at King's College London in a similar capacity. And I thought I'd start off by sharing a quote with from one of my students, on this project last year. And this quote was, "To say that you're actively being anti-racist seems a bit radical, especially in medicine." And I thought I'd leave that with you. It would be great to hear any reflections that you might have. Does that resonate with you? Does it sit well with you? Is it completely different to your lived experience or your practice if you work in the NHS, or different to if you work in academia, the ethos that you're following in terms of the course that you support on? But it really would be lovely to hear any reflections. Do you agree with my student, or do you disagree in terms of your lived experience at the end of my talk? Thanks. So just to share with you an outline of what I'll be going through today, I'll provide you with some background and context to the scholarly project module at King's College London. I'll share some insights into the group of medical students who conducted scholarly research into anti-racism and health last academic year. Following this, I conducted some educational research, so I'll share the findings with you of this research with a focus on the learning that these students said that they took from the project itself, and the learning that they want to take into future practice as doctors. And I'll close by discussing limitations, suggestions for further work, and next steps. So just to talk to you about the scholarly project module, this is a compulsory module taken by all Year 3 medical students at King's College London. It's a 30-credit module requiring students to engage with an area of scholarly research as assessed by their project supervisor, and to write a 3,000-word essay detailing their research and findings, with an emphasis on critical evaluation of the literature. What's really lovely is we put a call out to departments across the institution at King's. So we have project supervisors from social sciences, from arts and humanities, from medical education, offering scholarly projects, and students then self-select a project that they are intrinsically motivated to conduct. So they're passionate about this area, and they spend 1 day a week over 12 weeks conducting independent scholarly research into this area with the guidance and support of their scholarly project module supervisor. So some of that research is independent, some of that research is done under the guidance of the supervisor. Under my supervision, my students were offered 7 meetings across the semester last year, and these were a combination of different activities just to try and make it more interactive and varied. Students were offered the opportunities for check-ins. It was some of them the first time conducting a literature review, so I just wanted to know how they found that process. Student presentations, so presenting what they'd found, and what was really nice is I invited students from the group to watch these presentations as well. So students were often in the company of their peers, hearing each other's presentations. So it started to become a peer learning activity as well as a supervisory activity for me, just to sort of see where students were at and provide support. There were Q&A sessions as well, and input from researchers in the field. So specifically, the project I'll be talking to you about today was a scholarly project on anti-racism in health. And last academic year, 6 students were offered the opportunity to conduct this project for the first time. This was the first time a project like this had been offered. And unfortunately, as I've now left King's, it's not going to be offered this year, but there is scope for it to be offered in the future. And in my further work and next steps at the end, I'll mention the potential for this to be offered at other institutions as well, specifically Queen Mary, where I'm at now. So students were provided with this brief then, before selecting this project. I'll give you 30 seconds to a minute or so to read through it, and then I'll narrate it for those who perhaps can't see very well. So I've noted here, the notion that medicine has a number of biases has been established and well documented. One of these biases is a tendency towards stratifying patients by race when it comes to treatment, often with very little factual evidence to support these decisions. Over the years, many inaccurate assertions have been debunked. For example, the notion that Black patients are able to better tolerate pain, but both the historical legacy of this racist treatment and the fallout of this way of being treated for certain patients are yet to be fully addressed. We invite students to examine current practices related to any condition or medical area of their choosing and identify either racist or anti-racist practices. So the task then for students was either researching current ways that medicine is still treating patients differently due to race and suggest an alternative anti-racist evidence-based approach, or analyze and critique a current anti-racist practice that has been adopted in the UK or in global medical practice and consider its development and usefulness. If a global initiative is selected, the expectation was that students would also consider how this practice could apply to the UK population. So this was the task that I gave my students. So to share with you then the students who signed up to conduct this project and this research, 6 students, 4 female students, 2 male students, all 3rd year MBBS or medicine students, all ethnically diverse students, so make of that what you will. And some of the examples of the projects that they chose to conduct were disparities in the treatment of Black men presenting with mental health conditions, disparities in the mortality rates for Black women during pregnancy and childbirth, and 2 students, interestingly, took this in a direction that I couldn't have expected. 2 students elected to focus on racism within the medical workforce, the NHS. They thought, and they explained their thinking process to me, we will be going into practice very soon. We would like to know if there are any structural issues that we should be aware of before we enter the workforce. And they wanted to focus specifically on barriers to progression for non-white staff. So I welcomed that, just to see where they took this project. The educational research then that I conducted following the 12 weeks with these students was, I asked them to attend qualitative interviews, which 4 students participated in, where they were asked 10 questions about their experiences of the project. I then transcribed these responses and then conducted thematic analysis. I used reflexive thematic analysis simply because it encourages the researcher to think about their positionality. So my positionality as a South Asian woman, a pharmacist, somebody who's worked in the NHS and also an academic is really interesting. And I want to ensure that I mitigate how much that might bias the themes that I'm generating from the thematic analysis. And reflexive TA encourages me to do that through reflecting on the themes I generate and then consolidating them, reflecting again, really contextualizing them in terms of my lived experience. So these are the themes then that I generated. I'll share them with you shortly. Just before I do, I'm not going to share all 10 questions with you. That would take much longer than the session that I have with you today, but I've selected 3 questions. So 3 responses from students, 3 questions to share with you. The first question, student responses to, did anything surprise you? Second question, what will you take to your future practice as a doctor from your anti-racism and health research? And third question, is there anything that you'll take from the content shared in your peers' presentations into your future practice as a doctor? And I'll also touch on other responses when I ask students, is there anything more you'd like to share, just because the answers are quite relevant here. Okay, to start off with the answers in response to, did anything surprise you? So I've highlighted here the key theme, the dominant theme. 4 themes were generated in terms of the responses across the students who were interviewed. And the dominant theme was race-based injustice in healthcare. And students here shared with me, as part of their response to this question, they were so surprised at how many examples they found in the literature. Firstly, it was unexpected. They didn't think it would be as prevalent as it was. And when they did read the literature, the examples that they found were so diverse and surprising to them. So I've pictorially represented this here in a hierarchy chart, and you can see that the majority of the responses were around race-based injustice in healthcare. In terms of the examples, so many of them that students shared with me saying, Maaya, I didn't expect this, I didn't imagine this, this is what I found, as well as it being unexpected. You can see some other themes here as well. Students found conducting this type of research eye-opening. They talked about the fact that other people had done this research before and they were so surprised, but also felt solidarity, that they were so glad it was done. For some students, this was the first time they were conducting scholarly research, that they didn't realize how in-depth the process is, how much they needed to conduct the literature review and to look through and ensure that the themes and the types of papers they were looking through were relevant. And a final theme here that I'd like to share with you that you might note across the responses that I'll share with you as well, was the confirmation of known feeling with data. And what I mean by that is, students went on to tell me, do you know what? I found this in the literature, and actually I was on placement last year, and I had a gut feeling this might be happening. And now that I've read it in the literature, I feel validated. I feel like somebody's done research into this, and this is what I saw and felt. And now it's actually evidenced in the literature. And that went on to provide them with validation and confidence. And I'll mention that as a theme. You'll probably see that recurring across some of the responses to the questions I'll share with you. Second question, the learning to take to future practice from their own research. This had one dominant theme, completely unexpected. This is actually quite, in a lovely way, very much aligned with what Michael was talking about at the beginning of the conference. Students took from this research that they wanted to participate in building a culture of anti-racism. They wanted to shift the current culture, the current uninclusive, if I can call them that, practices within the NHS to become more inclusive and diverse and provide more of a sense of belonging for people from every ethnicity, every different background. And they took it that it was their responsibility. So this was both a personal approach that they wanted to develop. So you can see here development of a practitioner's own anti-racist approach. And that was split into students sharing with me that they wanted to talk about skills and behaviors that they wanted to adopt to support their patients. And they also wanted to learn new knowledge as well. And then on a more collaborative level, students wanted to talk about raising awareness of racism. So personally having their own anti-racist approach and then collaboratively raising awareness of it within the workplace. In terms of the skills and behaviors that they spoke about specifically, they talked about acknowledging the historical legacy of racism in medicine within their approach to patients, having a greater awareness of their own biases, the importance of context when treating patients, so taking into consideration a patient's background, their age, any other complex societal, political issues they may be facing by virtue of their ethnicity, and also adopting a more mindful awareness of the current ethnic disparities that exist within the NHS. And this is something I think I'm really, really proud of, that students took this from this research completely unexpected, but wonderful. The learning to take to future practice from their others' research, from their peers. The dominant theme here was structural racism within the NHS. So hearing a number of different students talk about racist practices that they had identified within the literature led students to understand that there was a prevalence of racism, and also that they wanted to start challenging the system and calling it out. And you can see that pictorially represented here. Confirmation of known feeling with data, you'll see that pop up again here again as well. So again, they may have been doing research themselves into, for example, Black men's mental health, but then they may have heard from a student talking about racism within the NHS workforce, and that may have led them to thinking, that resonates with me. I can understand why that may have happened. I observed that on placement last year, or I've seen that before. That's something I felt. They also talked about the value of building sort of proficiency in statistical testing research methods. So for some of them, again, this was the first time they were looking through literature and understanding quantitative literature and findings, and the value of collaborating with others in anti-racist research. I think that was taken from looking at the number of authors that they saw writing papers together collaboratively across different institutions, but also seeing members of their own group conducting literature reviews and research into different areas and seeing the value of coming together on this. That again was some really great learning to observe. And finally, other responses fell into two themes. The dominant theme being they really appreciated this novel opportunity to conduct research into anti-racism in health, but also again, when I said anything else that you'd like to share, there was the, and you know, when I heard this, that made me think of this experience I had, and now I just felt so much better because it wasn't just me. It wasn't just something I felt, it actually does happen, that validation. So just to briefly now give you a quick overview of the findings, because I've talked through it as we went through the results. Responses to what surprised you were categorized under 4 themes, with the prevailing theme being surprise at how much race-based injustice is present within the NHS, and that was towards both patients and ethnic minority staff. Under this theme, there were 2 sub-themes, students sharing how unexpected this was, and students giving numerous examples of systemic racism in the literature they discovered that surprised them. Learning to take future practice from own research came under one dominant theme, participation in building a culture of anti-racism. And the 2 associated sub-themes coming completely from my students was their own want to develop an anti-racist approach through skills and behaviors and knowledge acquisition when they are in practice, and a desire to raise awareness of racism within the environment in which they work. Learning to take to future practice from peer research presentations came under 4 themes, including confirmation of known feeling with data, which we've talked through. Structural racism within the NHS was the dominant theme, with 2 associated sub-themes, students gaining an awareness of the prevalence of racism within our healthcare system, so learning about that from their peers' research, and also students feeling more confident now to challenge the system and call it out. Other responses had the prevailing theme of students expressing appreciation for the novel opportunity to conduct anti-racist research. And as I mentioned before, confirmation of known feeling data was present throughout the responses in student responses to 3 out of 4 research questions. So that again implies that this research gave students a sense of validation and a greater understanding that these practices do still occur even in the workplace in which they are about to go and work in. So in terms of a critical evaluation of the research, this was the first time running this project and collecting this data. So there's no comparative data set. Also, and this was something that surprised me, there's very little reference to scholarship in anti-racism and health for medical students in the wider body of literature. So if there are people at the conference today who are thinking about conducting a project like this with your healthcare professional students, please do so. I think it would add to the body of evidence, and I'd be more than happy to help or compare findings. It would be lovely to do this. And then just taking us back to this project and looking at the impact of it, it did positively affect and equip students in actively wanting to participate in building a culture of anti-racism when in practice. To share with you a quote from one of my students, again, I'll just give you a few seconds just to have a read through this. So this student said, in my future practice, I think I'm going to take forward the idea of intentionality. I think that even in listening to the presentations of my peers, it became very evident that this is a thing you have to consider in practice. Maybe not have an explicit conversation with every single patient that these are the factors that might be affecting you, but as a medical professional going forward, these are vulnerable groups. And there's certain things either in our teaching or in the way that medicine has been created in the past that have made it a bit more difficult for them to get certain outcomes. So I think it's taking stock of your own personal biases and making sure that as you go forward, this is something you're compensating for in some sort of meaningful way. What I've highlighted on here, the intentionality and the quote at the bottom, to me that speaks to compassion. That speaks to adopting a compassionate approach when in that room with that patient and connecting with them, understanding that we want to make medicine more inclusive and more equitable for our patients. So they come in and they feel respected, they feel heard, they feel seen, they feel listened to, regardless of their background. They feel like they are in a situation where they are receiving compassion and they are respected. And that was lovely that this was associated with a student conducting scholarly research into anti-racism in health. So to close then with limitation, further work and next steps, my limitations, I was the researcher for this project. I was also the academic lead for the scholarly project module. So when I spoke to students about some of their questions, queries about the module itself, they did go a bit operational on me, the timetabling and things like that. So I think that sometimes led to me not having as much time as I would have liked to learn about their views of the module that on anti-racism in health, the project itself. And I got a lot of, which was really great, feedback about the module, but it would have been much more worthwhile to have more information about the anti-racism in health project. The research was conducted with a small group of students, 4 students, so I couldn't really conduct any meaningful statistical analysis. So it would again be lovely to hear from peers, perhaps who might be interested in doing something like this, collaborate and think about how we can get greater numbers of students perhaps getting engaged with this type of research. The ethics also of me as the researcher, also being the supervisor for the project. Let me tell you, I don't think it did stop students holding back from critique, but there is an ethical challenge perhaps that may come from me being the researcher and the supervisor as well. My subjectivity in reflexive thematic analysis, but as I said, I elected that process specifically so that it would mitigate any bias and actually take on board my subjectivity in a meaningful way. And finally, then further work and next steps. So this research was presented at the Brighton and Sussex Medical School Anti-Racism in Healthcare Conference in March of this year. A student from my group also presented her research, her scholarly research in anti-racism in health at this conference, and I was incredibly proud of her. I also presented this research at the King's Education Conference in June of this year. And there's the possibility, as I mentioned at the beginning of this talk, of introducing this project into the medical school at Queen Mary's. But again, I would love to collaborate with anybody who might be interested at the conference today on work like this. So please feel free to reach out to me. Thank you so much for your attention today, for the time, for the opportunity, Sarah, to present at this conference. Thank you. I'm so incredibly appreciative. If anybody has any questions or would like any further information about this project, please feel free to email me. My email address is there. Thank you. Thank you so much. Thank you.
Thank you, Maaya. It's been absolutely delightful to have you, and especially discussing about your research or a kind of approach, your teaching and research approach for this important topic. Thank you. I don't think we have any questions. Yeah, no, I don't know whether we have any question from the audience. Just
Maaya, what I can do is put your email address again into the chat. I'm sure that especially my ears are pricking up as an educator about the opportunity to collaborate in the future, and I'm sure many people would also out there be thinking about that. So I'll put your email, if I may, your Queen Mary email into the chat so that people can do that. So thank you so very much.
Thank you.
Great, thank you.
thank you.
Yes, it looks like people are saying it'll be good to speak to you, Maaya, so I'll do that. We're going to go to a short break for the next 15 minutes. For those in the room here, give you time to go and do whatever you need to do. For those at home, grab a coffee, a hobnob, or any other biscuit that is of choice. And we will see you back here in 15 minutes for our next presentation. Thank you very much.
Okay, brilliant. Well, welcome back off the break. The observant among you will notice I'm wearing a coat. I'm not going anywhere. It's just a little bit chilly in the lecture theatre this morning. But our next talk is by Dr. Alison Sykes. And Dr. Sykes is unfortunately unable to join us in person today due to a bereavement. We are fortunate to have a recorded presentation titled Compassionate Leadership Through the Heart, Mind and Soul of an Emergency Physician. Dr. Sykes serves as the Director of Postgraduate Medical Education and Consultant in Emergency Medicine at Lancashire Teaching Hospitals NHS Trust, where she has championed compassionate leadership in emergency medicine. As a compassionate ambassador with Stanford University, she has developed and delivered numerous training courses in compassionate leadership, working with healthcare professionals across all levels. Under the mentorship of Professor Michael West and Professor Paul Baker, she has pioneered approaches that bridge the gap between theoretical understanding and practical application of compassionate leadership in healthcare settings. Her work has been particularly influential in reshaping how we integrate compassion into medical education and clinical practice. So in a pre-recorded video form, I'm pleased to welcome Dr. Alison Sykes.
Hello, I'm Alison Sykes. I'm a consultant in emergency medicine at Lancashire Teaching Hospitals Trust. It's a pleasure to be with you and a privilege as well to share with you my own experiences into compassion and compassionate leadership. In order to do that, I need to go back to 2019 and share with you the start of my journey. So as an emergency medicine consultant, we run accident and emergency departments, and this particular shift I was on duty and on call. And that means that I'm there to troubleshoot all sorts of problems for anybody really. So the team I was looking after, my trainees, my peers, my colleagues that I was working with, and also the wider hospital community in terms of getting patients into beds and flow through the hospital. Many of you will know about the problems we have in accidents and emergencies up and down the country in terms of exit block, where we can't get patients into beds. People spend a long time in our accident and emergency departments, either on trolleys or on chairs. And it's a harsh environment and one that's difficult to exist in and retain your sense of self, I think. And this particular night was no exception. It was busy. I'd already seen lots of patients, but I'd seen a very sick lady, an elderly lady, and she was very poorly, which had been unexpected. Trauma call goes off. I need to go down to resus, and I also want to hand over this lady to the medical registrar who's in the department. So I asked if she would walk with me down to resus while I told her about the patient and made my way through for the next trauma call, for the next patient. And as we're walking along the corridor, I turned to the medical registrar and in an audible voice said, she'd not do well, meaning the patient that I'd just seen. What I became aware of was a family to the left of me who heard every word I said. And I don't know to this day whether they were the family for the patient that I was talking about, for the person I was talking about. But I knew in that moment I was a long way away from where I wanted to be, and indeed where I'd started my career in medicine. It wasn't me to talk so carelessly about the life of another. And I still feel ashamed about it. I still feel it, and you can probably hear it in my voice. So that was my starting point, really. That was the moment where I recognised that I was also suffering. Not long after, I was lucky enough to hear Michael speak. He was speaking at the Foundation conference up at Grange, talking about compassionate leadership. And as he was talking about his experiences of speaking to our resident doctors, about their experiences working in the hospitals. And that really crystallised it for me, because everything he was talking about was also happening to me. The lack of food, the lack of somewhere to sleep. And I realised that I too was suffering. And the reason I've said that twice now is because that's really important, because as doctors, I don't think we see that we suffer. I think we look around and we see how everybody else is suffering. I think we consider suffering to be the heart attack that somebody's experiencing or the traumatic injury from a car accident. And we don't ever realise that there are multiple times through the day where we too suffer. And compassion can and only will arise in response to suffering, so it's kind of important to notice it. And certainly helpful for me to be aware that that's where I was, and also not where I wanted to be. Listening to Michael opened my eyes, really, to a different way of being. I was a bit scared about that, I think, initially. And slowly I started to alter the way I was in the department. So when you walk into what is an overwhelming environment and there's patients waiting on trolleys, lots of patients still waiting to be seen in the waiting room, and you're going to be there till who knows when, but you know you'll definitely hand over at 8 AM, it can be overwhelming. And I'd adopted a stance of walking with my head down, not looking at the patients on the corridors, definitely not engaging with them. And slowly what I did was I began to look up. I began to look at my patients in their eyes, and then eventually began to smile. And slowly, small steps, I would then say to them, "Can I do anything for you? Can I get you anything?" As a doctor, my priorities are about making sure people get the right treatments in a timely fashion, and ideally in the right place. Invariably that means initial treatment with me, an accident and emergency, but then onward care on the wards. But more often than not, when I said to patients, "Can I do anything for you? Can I help you?" they would ask for a glass of water, blankets, a pillow, perhaps to ring a loved one, sometimes for a hot drink. They weren't difficult things to do. And what I noticed in me was that the more that I engaged in that kind of activity, the lighter my load felt. It wasn't that my load was lighter, but it felt lighter. It felt that I could do more through that connecting with the people in front of me. And that made a huge difference, because it made a harsh environment gentler, easier, kinder, maybe, hopefully. And it made it sustainable. That was the other thing. Not long after, I was asked by our foundation school director if I would see if I could bring compassionate leadership to foundation. And in that, I was lucky enough to be able to work both with colleagues up at Lancaster University, but also with Michael. And we devised a foundation programme for compassionate leadership, because we know that foundation doctors suffer more burnout than any other medical grade. And they're also the most compassionate. We know that compassion declines with medical training. So it made sense to deliver a compassionate leadership programme to the ones most susceptible to burnout, but also the ones that were already the most compassionate. So over the last few years, that's what we've been doing. So from a position of doom and gloom, I suppose, hopefully we've got some rays of light, and I look forward to seeing what their futures hold for them and how things change, actually, because it's those small steps that I believe really will make a difference. So that's my story, that's my journey into compassion. I hope you enjoy the rest of your day together. It's been a privilege to be with you, and very, very grateful for all that you're all doing for everybody. So makes a big difference. Thank you. Bye-bye.
I think it's always really powerful when we have these conferences, when we hear the personal narratives and how often change begins with somebody's own journey. And that was a really incredible example of that. The other thing I'm also very reflective of is how when we talk about compassion, we actually do talk about small steps, or in this case of this talk, looking up. And how powerful is that to change your gaze and to just notice the small things that you can do, asking, how can I help? And then the reaction being actually small things that you can do, which will make a huge difference in that person's journey. I don't think, in my opinion, compassion needs to be complicated. And I think it can be in the everyday small task or biding a little bit of time. And for me, again, the personal narratives that we hear are incredibly powerful. And even those 9 minutes there, I'm absolutely confident that we can go ahead and do wonderful things by looking up. So really good reflective kind of talk there, very powerful. Passing on to my panel member here now for the next talk.
Introducing two speakers now. The first of those speakers is Paquita De Zulueta. Paquita worked from 1984 as an inner-city London-based GP with a special interest in mental health, migrant health, clinical ethics, professional education and development. Paquita has worked for 10 years as a part-time clinical volunteer for Doctors of the World London Clinic and for a few months during 2017 and 2018 as GP lead for the NHS Grenfell outreach team. Paquita has been a senior honorary lecturer at Imperial College since 2000 and has been teaching and writing about clinical ethics since 1993. Since 2008, Paquita has also worked part-time CBT, which is compassion-focused, and EMDR therapist. She's also a qualified coach and mentor to mainly healthcare professionals. She's also a Schwartz round facilitator and on the steering group for medical student rounds at Imperial. Paquita is also the chair of the charity Human Values in Healthcare Forum. Over to you, Paquita.
Okay, good. Sorry, I'm in the webinar. Yes, it's an honor to be here. Absolutely delighted. As the kind introduction, I'm Paquita. I'm the chair of the Human Values in Healthcare Forum. And I'm just going to share a slide just to very quickly introduce you to what we're about. The Human Values in Healthcare Forum, or HVHF, was around since the 1980s, actually, when it was set up by a group of distinguished doctors and a social scientist. And then there was a nurse as well, a senior nurse. And it really started with the having read the Nazi doctors, and they thought, my goodness, a profession can become so corrupted in its values in certain contexts, and could something like that happen here? And then it moved on to looking at vulnerable groups, marginalized groups, prisoners, asylum seekers, and so on, and also looking at technological advances in healthcare and how that could impact again on human values in the healthcare setting. And then it was reignited more recently, and we're now a charity. And our key mission really is to humanize healthcare. And we do that by supporting and collaborating with those who are working as well to promote human values in health and social care, like C4CHEd. And we also kind of aim to raise awareness and challenge dehumanizing practices and policies. And we aim to be a community of practice and a learning organization, and providing educational and reflective spaces, promoting interdisciplinary dialogue. And I'll talk a little bit more about that. And we explore ethical issues and challenges in everyday healthcare. And as I said, scientific, technological developments. And for example, we ran a conference at Oxford with the Centre for Collaborative Values-Based Practice on AI and relational care with a number, it was multidisciplinary with a number of experts in the field. And our values obviously include compassion, wisdom, integrity, inclusivity, courage and justice. And as I said, we are a charity, and we'd be delighted if you join us. We have a quarterly newsletter, and so not to bombard you too often, and we sort of put resources there, interesting and relevant articles, webinars, podcasts, and so on. And I'm just going to share the second slide, which hopefully will appear, which is Reflethics. So we've just started this in November, which is basically facilitated ethics conversations, multidisciplinary. We try and limit the number to 10, and it's facilitated by someone like myself who has a background in clinical ethics, and co-facilitated by an experienced leader in running groups and educational groups. And we aim to provide a confidential safe space, and have just drop-in monthly conversations at lunchtime. And we had one in November, which went very well, was definitely multidisciplinary. So bringing together nurses, doctors, allied health professionals, we even had a manager. And so we're going to continue with that. We're not going to have one in December, but there will be one in January, which is almost nearly fully booked, but you can sign up for subsequent conversations. And if it's successful, we'll have two a month. And so now I'd really like to pass on to my wonderful colleague, Serina Aboim, who is also, I'm going to stop sharing. So I'd like to introduce my wonderful colleague, who's also a member of the HCHEd team. She's clinical lead for the Homelessness Community Service at Guy's and St Thomas's NHS Hospital Trust. She's an advocate for equality and inclusivity, and she specializes in inclusion health for those experiencing homelessness, with a particular passion for supporting women who are homeless and for their health. She has a clinical background in emergency nursing and cardiology, and she's worked with homelessness for 14 years. She's actually involved in several projects across London, and she set up the first street nursing service in London, in Southeast London. So I'm going to pass on to you, Serina. Thank you.
Thank you, Paquita, for that introduction. I'm just going to share my slides. So this presentation is about, the title of it is about caring for the most vulnerable in our communities, a story of compassionate care. And as Paquita has kindly introduced me, so I work within health inclusion speciality, and particularly around the homeless service at Guy's and St Thomas's Foundation Trust. So the aim of my presentation within this next kind of 16 minutes that I have is really to share the story of compassionate nursing, being the centre of what my service does, what we do in health inclusion, to share a story about compassion in homelessness and inclusion health nursing. And also maybe just to touch on how we can empower the most vulnerable in our communities. So nursing vulnerable groups in society. So first, just to talk about what my service does. So we are a nurse-led service in Guy's and St Thomas's for community, and we work in hostels, day centres, we do street nursing, and we cover the addiction services in certain boroughs. And in the other stream, we have refugee asylum service, where we have a nurse-led, also GPs working in the asylum hotels across certain boroughs. And I say within the homeless service, people say, how did you describe your nurses? And I say, we're like a bit of a mix. So between like a district nurse, an A&E nurse, a practice nurse, and a bit of a social worker. So it's very, very holistic type nursing. And as Paquita said, we started a street nursing service in 2017, and we were supported by the Queen's Nurses Institute. And that's really about reaching groups on the street, because not everybody comes into homeless day centres. So this story is really about somebody that really, I felt really resonated to talk about an example of compassionate care. So before I go into that, people here may already know, so homelessness is a widespread problem which can lead to high vulnerability and social exclusion. Many reasons why a person may become homeless, which, relation breakdown has been reported as a common cause. Homeless people often encounter a number of other problems, such as mental health, physical health issues, and problems of drug and alcohol, which may present either as a cause or the effect of homelessness. And this list is not exhaustive. There's many other reasons. Unfortunately, the most recent statistics is showing the number of people facing homelessness is rising again. And this snapshot, the evidence was from up until June this year. So compassionate approach towards the homeless is crucial, and whether this to support with basic needs or an implicit approach in encouraging motivation and independence to help people to rebuild their lives. So, story of compassionate care. Sarah was living in a construction site and also on the streets of London. She was brought up in the care system and had no contact with her family, including her 5 children who reside with family. They're not in her care. Sarah was a victim of sexual assault and had a history of drug dependence and chronic hepatitis C infection. And just to say before I continue, the story can be quite sensitive, and it relates to termination of abortion. So if anyone, just kind of given that warning about any triggers for anyone who's watching this presentation. Sarah was identified by a street outreach worker following a referral on StreetLink as rough sleeping in a construction site, and was suspected to be pregnant. The outreach worker requested support from the nurse for an urgent pregnancy test to determine pregnancy status in order to apply for emergency housing. She was offered to see the nurse at the day centre, however, she declined. So a joint outreach shift was arranged with the street nursing service and the outreach worker. The outreach workers tend to be from charities. The aim of this was to build rapport and trust, and they attended the building sites once it was approved safe to enter by the contractors. The pregnancy test was positive. The current gestation was not known at that time. Sarah was counselled through her options to ensure she could determine when, how, and whether to bear children, maternity referral options, access to essential sexual reproductive health information and services, and to be free from violence. Now, after difficulties in contacting Sarah from the initial assessment due to their housing situation and her mobile phone being stolen, Sarah was eventually placed in emergency accommodation 3 weeks later. So Sarah requested that she would like assistance with a termination of pregnancy. So the nurse booked and supported Sarah to a face-to-face consultation at determination of pregnancy clinic. And this was over 2 consecutive days. The gestation was identified at 21 weeks. She was further supported to these appointments, and the nurse held Sarah's hand whilst in theatre at her bedside during the termination. This was her request. She wanted to keep the fetal remains after the TOP. The nurse coordinated with her local funeral directors and accompanied her to multiple appointments to assist with organising a funeral. The nurse was able to coordinate a funeral, an urn, and a private limo transport free of charge through fundraising and generosity from the funeral director. Sarah did not make the funeral on the day, but she did send this message. I'm so very grateful for all your help. You stayed at my side. Not sure why though, really. I won't ever forget what you did. I really couldn't have done any of this without you. So that is the story, but I just want to touch in about the elements of the impact and the engagement with this particular patient. So it's about the interpersonal approach. So the following recommendations are based on the views of people with experience of homelessness. Being friendly, compassionate, and respectful. And this is the words of someone who was a 44-year-old British woman who had been homeless for a month. They said, show respect is the basis of any decent interaction. A human connection that makes people feel cared for and included. A 56-year-old Latvian woman who had been homeless on 2 occasions was asked how she would feel about healthcare worker visiting her on the street. She said, I would feel very good. I would feel someone was seeing me, that someone cares for me. Compassionate care. So in healthcare settings, kindness is deeply appreciated by patients, but I feel it's often overlooked. A study aimed at defining kindness in healthcare found that actions such as greeting patients with a smile, asking about their daily lives, listening carefully, and showing interest significantly correlated with the patient's perception of kindness. Compassionate interactions, just linking to the story I have just shared, person-centered, empathetic, non-judgmental. Recognize that people's behavior and engagement with services is influenced by their traumatic experience, socioeconomic circumstances, and previous experience of services. And very key in the work that my service does is about trust. Healthcare providers are, we're considered the prime provider of compassion in healthcare, although most health providers decide to provide compassion and patients expect to receive it. Compassion is the foundation of good health. It recognizes the concerns, the distress and suffering, and taking action to relieve them. It is the base of listening, respect, empathy, communication, interpersonal skills, and knowledge and understanding of the patient's life and preferences. At its core, it means treating patients as people, not just an illness. And the story I've shared is really key. It's not just about the pregnancy. It's not just about Sarah's hepatitis C. It's about the individual as a person. And just to say, Sarah's name has been changed and elements of this story as well has been slightly changed as well to protect her confidentiality. How can we make a difference? Empowering the most vulnerable communities who experience a cumulative impact of health inequalities. Challenging the stigma. Simple encounters matter. Those conversations, those simple human connections, acknowledge dignity is therapeutic and the importance of the voice being heard. And I've mentioned some of these points already, but also time is really key as well with individuals. I know that's kind of constraints in different healthcare settings, but within vulnerable groups, time, whether it's language barriers, where you need to use interpreters, or whether you're just able to give that eye contact and that time. So I have some references and also a resource about how to hold conversations about health with those that are experiencing homelessness. And that's the end of my story about Sarah. Thank you very much.
Thank you, Serina. One of my colleagues on the panel, Riya, has had to actually go. She has to go to work. So I'm going to just ask a couple of questions and also see if anybody in the panel, in the audience here or at home have got any. One of the things that I've noticed that has come up from all of the presentations this morning is that concept of showing respect. So there are many concepts that link, that travel alongside compassion and are integral to it. But Maaya earlier on talked about her medical students working out that respect was such an important element of addressing racism in practice. You've talked about respect for a very vulnerable patient group, but also Helen talked about the fact that when you're faced constantly with really distressing circumstances, that can really have a negative impact on you. What do your team do to try and mitigate some of the challenges? Because the patient group you care for are a challenging patient group, and it's not always easy, and they're not always receptive. So how do you deal with that and maintain your compassion focus?
I feel we're quite fortunate because I provide all staff with one-to-one or group supervision with a psychotherapist who comes into service and enables the nurses to talk about cases and to share, because I didn't say, we don't work as a group, we work alone. So it's autonomous nursing. So you can carry that. You could carry those the hearing the stories, to why people become homeless. So it's a way to come together and to share, and that people are not alone. So I think it's really key about group supervision. And I know that within the Human Values for Healthcare Forum, we've also got some groups as well about those discussions, like ethical group and ethical discussions. So that's available to staff as well. So it's really key because we're working for quite a vulnerable group. It can make the mind quite vulnerable for staff as well in stories that we're hearing. So it's definitely an important element that is embedded within my service.
That's good. Just looking at one of the questions in the chat, John has just highlighted the fact that time is an issue for us all. We're all, I think, hopefully compassion focused, but time poor sometimes. And one of the things from my own research has highlighted the importance of intentionality, that we can't have any more time. Time is finite. But what we can do is think about how we use our time. And I think that was highlighted by Alison's talk about how when she changed her focus, she didn't have any more time, but her change of focus actually lightened her load. So you lighten your colleagues' loads by providing them with an option to talk about it, and to also address the fact that some of these things are very ethically challenging. And it's ridiculous to brush it under the carpet. Sitting with somebody and holding their hands while they have a termination of pregnancy is going to be tough for everybody. Very much obviously for the woman herself, but for those around her too. And we ignore it at our peril, I guess. So it's great to hear that you do that. Paquita, maybe just coming back to you, as you're happily still on the call here at the moment. One of the things about I'm going to struggle to say
it's a tongue twister.
Reflethics. It's only limited to 10 people, but can they come from anywhere? Because there's been a couple of questions about it.
Definitely. We had people from various parts of the country. So we're delighted. And it's so nice because you get a much richer perspective that way. And we know that, and there is evidence, and I should have said that maybe, that having these kind of conversations does reduce the moral distress. And it gives people that confidence, and you could say moral resilience, which is something that Cinda Rushton talks about. So we feel, and there's no evidence it does any harm. So I just say that. Yeah, what was your original question? It was whether anyone could join. No, definitely. We limit it to 10 really to create that sense of, of intimacy and safety. Obviously, it does depend on the participants that they don't share, personal information about what they've heard, but they can obviously share the stories and what they've learned. But if there is demand, we will increase it to bi-monthly and have it at Friday lunchtime as well, once a month.
I'm afraid I might rather create some demand, because
Yeah.
I'm going to share, and this has now gone into the chat,
Right.
and I'm very happy to a bit like Conversations in Kindness, one of which is tomorrow evening. No, sorry, next week evening, isn't it?
Yeah, with Bob Claver. Yeah, Bob Claver gave a talk. Just also to say that we have an annual event, which is really more a replenishing event in a lovely retreat centre in London. And that again, people from all sorts of places and disciplines come to it. That's limited to about 40. It's an in-person event, but it has been very successful. So we've had 2 of those. And we use creative inquiry, but we also have some presentations as well. So we had Bob Claiborne an interview with me and so on. So,
and Bob, who you're talking about, is a paediatrician in London who is organises a monthly conversation about kindness.
Yes.
Which is free to join. So if you look up Bob Claber, Klaber, I don't know if anybody's got a link to it and can shove it into the chat for us, but his Conversations in Kindness are free to attend and attract an international group of people who just want to come together to talk about the importance of kindness in healthcare and the impact of that. I'm really grateful that you came in a little bit earlier, because obviously Alison unfortunately wasn't able to present, but brilliantly sent a talk for us. So it means we are a bit ahead of time, but unless anybody has any questions on the panel or out in the audience, then I think what we're going to do is, because we have Roshni's writing workshop, I'm going to give people a bit more time to perhaps get themselves some lunch and so on, so that they can go and join Roshni's writing workshop. So thank you very much to Serina. I hope your son's graduation goes beautifully. Serena's just off to Nottingham for that. And Paquita, always lovely to see you. Thank you very much. And
thank you.
I'm just going to talk very much to the audience here and also to those at home. We have the absolute kindness in healthcare. Thank you, Wendy. That's brilliant. Bob Claber's link there. Again, another free initiative. One of the things that is really heartening is how many people are working around this subject: compassion, kindness, caring, empathy. And most people are trying to make it as accessible as possible. Bob Claber doesn't charge anything to join the Conversation in Kindness. It's online, it's an hour, and it's just people talking about there's often a presenter who comes up with an initiative that they're working on. It's a really good thing to do. That's free. Human Values in Healthcare Forum is free. This is free. Many people are trying really hard to live the value that they're trying to expose as well. And one of those people is absolutely our next speaker, who's or collaborator, who's Dr. Roshni Bahari, who is an educator, medical educator, a previous consultant in the NHS, and has now set up a Writing for Wellbeing course. And it's her business, but she brilliantly donates her time and her expertise to us in this conference. And she will be running an online workshop that starts at about past. It gives you some time to go and get a drink or a sandwich or whatever. And do feel free, as Roshni's just put in the chat, please feel free to take your lunch to the workshop. It's fine, you can do that. For those of you who are here in person, we have a classroom 2 floors up, 206, and Hazel is going to be there. So the online workshop, you can join it as a group. I can't recommend it enough. I'm always really disappointed that I don't get to it because I'm here, but Hazel will be up there. So feel free to go up. For those of you who are online, there is a specific link. You have to leave this Zoom and go into the separate Zoom to join the workshop. But those of you in person, you can go upstairs and join in online in person upstairs. Look forward to seeing you back here afterwards. So if you do leave to go to Roshni's workshop, and I absolutely would recommend you do, please do make sure you come back into your original Zoom link to come back for this afternoon's sessions as well. The workshop with Roshni won't be recorded. It will be a workshop. You will have the ability to talk and interact with her, although she's in London, and with whoever else joins from across the country. The link, Rachel, is a bit further up in the chat. If you go up just a little bit, it says workshop with Roshni Bihari, and there's a link there. There's another one now. So there's several links, several options of the link being put in. So please do click away. So we'll cut to a break. We'll have some lunch. Hopefully you will, but please feel free to take your lunch into Roshni's workshop. Thank you.
Okay, so welcome back from the break. I hope you enjoyed the workshop for those that attended, and it's good to have you all back with us. I'm now delighted to introduce our next speaker, who is Caroline O'Regan, who will present on the RCSI CPD Compassionate Action Learning Facilitator Training Programme, thankfully also known as CARF. Caroline brings over 3 decades of experience in healthcare systems leadership in her role as Programme Director and Executive Development Specialist at the Royal College of Surgeons of Ireland. As a founding member of the Office for Health Management, she helped establish the Health Service Executive and has since trained over 3,000 senior leaders across healthcare services. Her expertise spans executive coaching, healthcare policy reform, and system-wide organizational development, complemented by an MSc in Education and Development and Compassionate Training at Stanford. Currently serving as Honorary Editor of the Health Management Institute of Ireland and on the Executive Committee of the European Association of Hospital Managers, Caroline's recent work has focused on developing multidisciplinary and executive compassionate leadership programs. Her commitment to sustainable health reform has shaped collaborative practices across the healthcare sector. She has been particularly influential in fostering international collaboration, having led the Executive Systems Leadership Programme under the Hope Exchange Initiative for EU healthcare leaders. Caroline's passion for building healthcare systems rooted in collaborative and compassionate leadership has led to the development of numerous successful programs, working in partnership with the HSE RCSI to support compassion practices across healthcare leadership, teams and systems. So it's great to welcome Caroline, who hopefully is online. Yep. Hello, Caroline.
Hi, how are you? Can you hear me?
We can indeed.
Oh, great. Thank you for that embarrassing introduction, but thank you. And I am very privileged to be here today. And I want to send a big thank you to Dr. Sarah Tobin for the invitation, and to Alistair, who has dealt with all of my weird technical issues in the background. So thank you to you all and the team. So I'm very privileged to be here to join you today, and what a lineup you've had this morning. I have a brief, and I'm going to just explain some of the initiatives that we're involved with nationally and internationally. And my apologies up front if some of my initial slides have some overlap from some of the eminent speakers who you heard this morning. So if it's okay, I'm just going to share my slides now and talk you through some of the stuff that you might be interested in. So I work in the RCSI, the Royal College of Surgeons. I'm located in Dublin, but we do work locally, nationally and internationally. So we spend a bit of time in the UAE working with leaders and managers and clinicians, primarily in health and social care. And our biggest driver at the moment is to look at how can we support leaders and managers and systems across health and social care, nationally and internationally. And I'm sure you've heard this morning. And again, as I say, my apologies if I'm reiterating the obvious. So lots of the drivers that underpin our commitment have to do with the vacancies that we can see across our services in Ireland, and the issues with retention and the issues with global competition. We can see huge levels of staff stress and an intention to quit, especially in our clinicians, which is not good. We can see a huge demand on our service delivery. So we have an aging population, which is fantastic because of the advancement in medical technology and interventions. However, that is obviously on our services. We also have an ageing workforce in health and social care. So our predictions in Ireland, by 2030, we will have 68% of our 147 whole-time equivalent people working in our health services executive will be over the age of 65. So that has an issue for us in terms of workforce retention and workforce planning. So what we learned from COVID, like the rest of the world, we need to change our models of leadership. We need to change our models of working with people in health and social care. We have a huge population of highly motivated, highly educated workforce who come to work in a service, and our systems were very hierarchical and bureaucratic in terms of command and control. And we've learned that doesn't work. And we have estimates coming from WHO talking about the long-term health care workforce of 1.4 million by 2030 in Europe, and globally 12.9 million, of which 5.9 million will be nurses. And what we're finding in our college, which was established in 1784, that we have never had an issue in terms of the numbers of students coming in to the profession and the vocation of healthcare, whether it be in medicine, whether it be in nursing and midwifery, whether it be in pharmacy or any of the health and social care. This year in 2024, we had the lowest numbers. So even attracting people into the profession of health and social care is something that we're very mindful of. And we work very closely with the Health Services Executive. And the Health Services Executive in Ireland is like our health body that provides public health to the citizens of Ireland. And as I said, there's 147,000 whole-time equivalent people working in health and social care. So in our college, we work very closely with the people in health and social care, the CEOs and the senior executives, to look at practices that we can help support the development of leadership within the health and social care areas, but also to support high quality performing teams. And we focus on compassionate leadership. And we do that because as a college, we have seen that it's very evidence-based from a clinician perspective, but even from a leadership perspective, right down to any causal chain you'd like to look at. And I know Professor Michael West spoke with you this morning, and a lot of the work we do is in partnership with Professor Michael West and builds on all his research evidence. We know that if we focus on this, it causes psychological safety, which leads to high-performing teams, which then in turn leads to better patient outcomes. We know that it enhances retention and staff well-being and intention to quit. And we want to build these practices in Ireland so that we will have meaningful change and that everybody is kept within the family of health and social care. So we are committed to this approach as an organisation to prioritise compassionate leadership and practices. There, in turn, that we're supporting leaders to help them navigate. We're going through a huge change in Ireland from a strategy point of view, and we're restructuring how we deliver care in Ireland. It's so important right now that we have those practices to support these leaders who are having to make these changes and indeed sustain these changes with integrity and compassion. So why are we doing this? Well, we know from the global challenges, I mean, this works. You know, we have the evidence, we have the clinical evidence, we have the peer review evidence, we have the global evidence. So apart from it being the right thing to do, it's an imperative around the sustainability of our world and indeed the workforce sustainability. We know from an educational perspective that this helps leaders. We have heard this from an impact point of view when we've gone out to talk to leaders, because it equips them with the skills and tools to help them work as leaders with highly educated people in an inclusive way, and that they are working in high equality but highly effective teams. And we know that it enhances the educational sector, but it also enhances the health and social care sector nationally and internationally. Because again, as I said, we are helping people with some of the skills to help them as leaders as they face into the challenges that we all face in the world. And a big concern that we have in our college is around sustainability. And that's sustainability for our world globally, but also sustainability for our staff well-being. We really want to retain these great people that we have to come and work with us in health and social care. And we know that compassionate leadership and the practices of compassionate practices can reduce burnout, but it also can have a cyclical effect on organisational well-being and in terms of the health and well-being of the people who come to work in our organisations. We know that when we train leaders in these skills, that they in turn prioritise staff well-being. And this in turn creates a very supportive work environment where people are happy in their work and are valued in their work. So the long-term sustainability and continuity of care positively influences the patient, which is what we're all about. And this is all through compassionate practices. So far in our college, we have been introducing the work of Professor Michael West and Markovich that did a huge amount of work on teams, high quality teams in Lancaster University back in 2015 and 16. And we looked at the research evidence and we applied that to team development. And since then, we have applied all of the practices around compassionate leadership. Excuse me, and we've integrated this approach across our undergraduate programs for doctors, for nurses and midwives, for health and social care, but we've also introduced it as part of our postgraduate programs. So where I work in the Graduate School of Healthcare Management, we've integrated compassionate leadership on our Masters in Leadership and Innovation, on our Masters in Healthcare Management, our Masters in Quality and Healthcare Management, and a new program that we recently launched, Ascensions in Healthcare Leadership. So what we have done is, from an academic point of view, we have seen the evidence and the importance of including this to equip our leaders, but we've also then taken this approach for our non-accredited executive development programs. And they're the programs that we have designed and developed in partnership with the Health Services Executive, and we run with leaders across our health services. We've also taken this program to the UAE. And recently what we have done is we have been working with Africa in a pro bono basis since 2011. So we support the Global Surgery, which was established to develop systems and surgeons in Africa. And there's a few of the countries that are involved. And what we do is we work with surgeons across these regions to train them in terms of clinical leadership. And recently we have included the behaviours of compassionate leadership. We've included leading teams through compassionate approaches, and we've included self-compassion. And this is an integral part of the support that we're providing. And so far we have 774 surgeon trainers, and 71 of those went on to do our professional diploma in clinical leadership, which is an accredited programme. But again, the similarity is it still has the whole module around compassionate leadership. We've extended that programme to anaesthetists, so we've moved away from surgeons, including them, but we've involved the anaesthetists in Africa. And then more locally, what we have done, we have integrated compassionate practices into our programmes. And as I said, we run in Ireland an executive development programme which holds about 56 CPD points. It's not accredited in terms of an academic programme, but it has CPD accreditation. We run this programme annually for clinical directors, consultants in different professions. We bring about 40 of them annually together, and it's a compassionate leadership programme. Again, we've been running this programme since 2017. It's very underpinned by the work of Professor Michael West and the work of Paul Gilbert, all around the areas of compassion, compassionate programmes, and TRACIAC and all of the clinical outputs, they're obviously included in that also. So to date, we've run 7 programmes. They're usually 3-day residential programs run over 3 modules over a 6-month period. And so far to date, we've put through 300 clinical directors, executive clinical directors, all medical doctors, consultants, professors. And we're running our 8th program starting in February of 2025. Since 2022, we have worked with the HSE and we have run 10 multidisciplinary compassionate leadership programs, again, underpinned by the work of Professor Michael West, who is a keynote speaker on the final module of each of the programs. We have run these programs, 10 of them, since 2022, as I said, and we have 400 health and social care leaders. So these programs are open to clinical and non-clinical leaders in our health and social care family. We don't recruit people to these programs. They're recruited by the Health Services Executive, and we run those programs in partnership. And the approach we take to these programs is very much co-design. So we spend a lot of time working with the HSE, our Health Services Executive, and asking them what areas do they want us to focus on. And then we make sure that the participants are happy with this. And last year we were invited to go out to the UAE to run an executive leadership compassionate program, which we did. And again, we had an audience of 29 CEOs, CFOs, CCOs, again, clinical and non-clinical leaders across the UAE. And it was based on the pillars of compassionate practices and compassionate leadership. And we have been invited back because the impact apparently has demonstrated that this approach obviously works there too. So we've been invited back. So we launched our 2nd program this month, and we're launching a 3rd program in January. So that led us on to develop an initiative that we called the CAF program. And the reason we developed this was because we said, why not have something that's standalone, that we can offer out to the system, nationally or internationally, that can be held by any system in health and social care. You don't necessarily have to go through a compassionate leadership development program. So what we did was we piloted a program and we offered it out to clinicians and managers across our Irish health services to see would anybody be interested in coming on this program and just enhancing or learning some of the skills of how do you facilitate compassionate practices at an individual level, self-compassion, at a team level, compassion within your team, or indeed as a leader, leadership compassion. And then in developing that, how do you work with groups that you're involved with every day of your working life and help develop these compassionate practices so it just becomes a way of doing things? So we got together and we looked at how would we design this, and we gave it 3 pillars, and we said the first pillar needs to look at individual support. So what we're finding through the research and the evidence is that we need to start with self. So how are you in terms of self-compassion? And I know this has all been shared with you earlier on today. So that's a really important component of this program. So the first module looks at self-compassion, you as an individual, you as a team member, you as a leader. Then we work on the 2nd level, which looks at how are you in terms of leading your team compassionately, whether it be your executive management team, whether it be your team within a patient group, whether a pathway team, but how are your compassionate practices within that team? And then we look at, and you as the leader, how are you influencing your leadership in terms of how are you turning up and demonstrating compassionate practices? And how is that impacting on the cultures that we're developing within health and social care? So as I said, the first one is around self, and we really focus on an awareness of individual struggles as leaders. Health is a serious, complex business, and people are turning up doing their very best. And sometimes there isn't the level of support, notwithstanding anyone's problem, but there just isn't the level of support. So we go into that whole area of the types of support that are available for you. And we normalize that this is a normal human behavior, and that is no self-judgment or criticism on how you turn up. And then we include some tools, techniques and methods to help provide alleviation in terms of some of the personal challenges that leaders and individuals and teams face. A lot of what we do is evidence-based against the great work from Stanford from Dr. Christina Neff and Dr. Paul Gilbert. So it's very entrenched in that evidence to support that this is really important. If we're not self-compassionate, it's challenging to be compassionate with our teams and as a leader. And then we talk a little bit about regulating our emotional systems. We go into a little bit of depth around the different threat systems, the drive system and the soothe system. And we do this because we're trying to build up the toolkit for leaders and people who turn up to our program so that they have something that they can delve in for themselves. So we spend a little bit of time on that. And then we move into the whole area of teams. And we try and focus on these three areas, which the first one is around empathy and understanding, because we know that compassionate teams foster empathy because they encourage each other and each of the team members to listen. It's quite contagious, really, within the team. And this in turn promotes mutual respect and strengthens the team cohesion, but it also leads into this whole area of psychological safety. So this is a really important component for us on this program, and we try and role model that in the groups when we're working with them. And we know that if you have got psychological safety and levels of trust within the group can actually be more authentic in terms of how they turn up. So we spend a bit of time on this. And then we talk about the internal supports and how that helps us get through the complexity of working in health and social care, because it can be a stressful environment. It's very challenging, and we're dealing with people's lives every day of the week. So we're very cognizant of that. And then we go into the area of leadership and organizational level. So how are you turning up as a leader, and what is your team dynamic like? Are you even aware of what your team dynamic is like? So we know that leaders who demonstrate compassionate leadership can help improve the dynamic of the team, and that in turn reduces conflict, increases innovation, and all of the beautiful things that happen out of that. We know, looking at some of the studies coming out of workforce planning and analytics, working with HR in the HSE and the CIPD in London, that this type of approach absolutely increases job satisfaction. And no doubt Professor Michael West gave some stats on the evidence that he has evident in the NHS. We also know, based on the research, that it helps enhance performance and productivity. Because teams led by people who have this approach innate to their leadership style are happier coming to work, they're more productive, and they're more motivated. And it encourages this environment that feels psychologically safe to give your best without feeling judged. We know organisationally, from a systems leadership point of view, that organisations that adopt this approach from a leadership point of view have better health and well-being outcomes for the staff that we employ. So it just seems such a common sense approach. So what we did with this programme was we offered it out to the system. We said we were going to focus on 3 pillars: self-compassion, team dynamics, and leadership. Our rationale for this was to try and build up a bank of people throughout Ireland and our health system that would be trained and developed to support embedding these practices at a local level across the system. And we're going through a huge system change at the moment. And we felt that by offering this, it would help support the systemic change in our health and social services. And we're seeing that it actually is supporting that. And it's helping to support developing cultures from the start of these changes that are embedded in compassionate practices. So it's a fairly simple model. We run 3 modules that are 3 hours online virtual programs. And during the 3 modules, as I said, they have 3 pillars. We focus on understanding compassionate behaviour. We focus on the application and reflective practices. We offer supervision, and we give 13 CPD points. We have run 2 programs to date. We are starting the 3rd program in January 2025. And what we have done is we have taken the behaviours of Professor Michael West, and basically we have married them to the action learning principles and approaches of Reg Revans. And this is what's given us this model. So Reg Revans would say that working compassionately with comrades in adversity is a key underpinning principle to action learning. And we know, having used action learning as approach to support people, that there is no action without learning. And we lean into that from a compassionate leadership perspective. So we use the 4 principles, and Michael West would have spoken to you this morning about those, and that's his great book. We give every participant a copy of that book, and we introduce the 4 stages of group dynamics. And this is really just going back to what Dr. Bruce Tuckman published about these 4 different stages, so that people are aware that when you're working with a group for the first time, that they will experience those different changes. We put huge emphasis on exploring how to create a safe space, and there's some of the guidelines and criteria that we use, and we try and role model that when we turn up to work with the groups. And we apply the basic skills of facilitation, and they're just very basic skills of contracting, communication, listening, questioning, cultural differences, and obviously a big area here is around making sure that timekeeping is adhered to. And as I said, we put people through the programme, but we don't leave them on their own. We bring them back for supervision. Some people don't like the name supervision, so we've changed it slightly to protect spaces to reflect. So it's really our way of supporting the people that we have trained in case there's any difficult areas that they want to talk about, or they want indeed to get some support from us in relation to how they're getting on. And we go into the 3 areas of supervision in this context, which is to help them be more comfortable in the role, help them maintain equality in relation to their work, but more importantly, make sure that they can feel reassured and that it's a safe space for them to go after working with the different groups. We speak about the different levels of empathy, and that really your job is to empathize, but they're not your shoes. So how can you step into those shoes, but then step back out of those shoes again? And where are we now? At the moment, we have run 2 programs. We're starting the 3rd program in January. The first program we ran, we opened it out to everybody, and we had 38 people participating on the program, clinical and non-clinical managers and leaders. The second program, we had 13 people. They were mostly CEOs and regional executive leaders. And our final program that we're running in January for this group, we've opened it out to both groups. So we're evaluating the first 2 programs. We've sent out some evaluation, and we've met with some people. We've done structured interviews and focus groups, and what we're finding is the feedback will inform future programs after 2025. So in summary, just really to say we are very committed to this approach because we know it works. We have the evidence from our research, but also from the pragmatic evidence and the impact evidence when people go back into their place of work. We know it is a call to action, and we are highly committed to supporting leaders, frontline people, clinical and non-clinical, because we know it leads to well-being, equity, sustainability of compassionate practices and leadership. And I'm finished now, I think. So over to any questions and reflections. I hope I'm okay on time. I know I ran through that. My apologies.
No, thank you very much for your talk. It was really, really interesting. Unfortunately, in the interest of time, we probably do need to move on, but there is a little bit of dialogue and questions in the chat. I wonder if you wouldn't mind having a look at. Be very interesting, and particularly like the emphasis on safe spaces. I think that's absolutely vital, immensely important. So thank you very much. Just going to pass on to Tosin now, who's going to introduce our next segment.
Yeah, thank you very much for that. Again, Caroline, thank you so much for that important description of the overview of your teaching model. I think it's important in such a time like this. So I'm going to introduce Dr. Tobin. She is a lecturer in adult nursing at the University of Plymouth here. Unfortunately, she is the founder of the Collaboration for Compassion in Healthcare Education, and it is safe to say that it's been an impactful program for the last 5 years. She qualified as registered general nurse in 1990 and then as registered mental nurse in 1992. Sarah has worked in a number of different clinical roles, including elderly care, emergency care, oncology, and cancer screening. She did a diploma and a degree in nursing and running alongside her clinical work as a nurse specialist, a lead nurse, and a matron within the NHS. MSc, master's degree, a felling in kindness and devastating impact on a patient led her to complete her studies with research to try to understand if compassion was important to those who provide care, and if so, whether it could be taught. The bit firmly between her teeth, she built on the findings from this work in 2013 and commenced a PhD program to try to establish a kind of definition of compassion in healthcare. Based on her research, Sarah set up the collaboration for this compassion in healthcare education and ever more convinced that compassion is a vital component of not simply human healthcare, but a sustainable, effective, and efficient care. She aims to try and establish understanding of this skill as an important element of healthcare education. Over to you, Dr. Tobin. Thank you.
Thank you, Tosin. So I've got a short period of time just to talk to you about what Schwartz rounds are and why do them. And the reason I'm doing that is because we're actually going to run a Schwartz round in about 20 minutes time. We're going to run the Schwartz round for those people who are present in the conference, but also for anybody in the wider university who come to them on a more regular basis. So Schwartz Centre rounds are named for the gentleman in the picture here, Ken Schwartz. They're a place where people who don't usually talk about the heart of the work are willing to share their vulnerability, to question themselves. The programme provides an opportunity for dialogue that doesn't happen anywhere else. And one of the things we've heard from the previous speakers today in the conference is that concept that we suffer too. And it's a concept that's not really been very well explored for years. We just got on with our jobs and did them. And the things we did daily, which to many people would be a nightmare, were our normal working lives. And then we would go home and carry on with our normal family activities and find some way to try and balance that. And that was not easy. So the Schwartz Centre rounds are one area that we can start looking at how we start to unpick that challenge of doing our jobs. In 1994, Ken Schwartz, an American attorney, was diagnosed with terminal lung cancer. During his treatment, he found out that what really mattered to him most were simple acts of kindness. He described them as making the unendurable endurable. He was well enough off to get very good practical clinical healthcare, but he realised that what made him get through his day was whether people were actually kind to him. I'm going to take 5 minutes just to read you his own story from his own words, because the whole initiative of Schwartz Rounds are named for him, and I think he'll probably tell you better than I can what matters to him. And I think stories are an incredibly important way that we share experience with each other, an incredibly important way to teach and learn. So I'm just going to share Ken's story. Until last fall, I had spent a considerable part of my career as a healthcare lawyer, first in state government and then in the private sector. I came to know a lot about healthcare policy and management, government regulations and contracts, but I knew little about the delivery of care. All that changed on November the 7th, 1994, when at the age of 40, I was diagnosed with stage 4 lung cancer. Oops. In the months that followed, I was subjected to chemotherapy, radiation, surgery, and news of all kinds, most of it bad. It has been a harrowing experience for me and for my family, and yet the ordeal has been punctuated by moments of exquisite compassion. I've been the recipient of an extraordinary array of human and humane responses to my plight. These acts of kindness, the simple human touch from my caregivers, have made the unbearable bearable. The day before surgery, I was scheduled to have a series of tests. The pre-surgery area of the hospital was mobbed, and the nurses seemed harried. Eventually, a nurse who was to conduct a pre-surgical interview called my name. Already apprehensive, I was breathing hard. The nurse was cool and brusque, as if I were just another faceless patient. But once the interview began and I told her that I had just learned that I probably had advanced lung cancer, she softened, took my hand and asked how I was doing. We talked about my 2-year-old son, Ben, and she mentioned that her nephew was named Ben. By the end of our conversation, she was wiping tears from her eyes and saying that while she normally was not on the surgical floor, she would come and see me before the surgery. Sure enough, the following day, while I was waiting to be wheeled into surgery, she came by, held my hand, and with moist eyes, wished me luck. This small gesture was powerful. My apprehension gave way to a much-needed moment of calm. Looking back, I realised that in a high-volume setting, the high-pressure atmosphere tends to stifle a caregiver's inherent compassion and humanity. But the briefest pause in the frenetic pace can bring out the best in a caregiver and do much for a terrified patient. I was greeted by a resident in anaesthesiology, Dr. Deborah Reich, who took my pulse and blood pressure and said gently, "You're pretty nervous, huh?" She medicated me with tranquilizers, but that did not stop me from asking about where she lived and where she had trained and whether she was married. I jokingly asked her how come she was the only Jewish doctor I had met during my time at MGH. When it turned out that she lived down the street from me and liked the sandwiches at the same shop, Virginia's, I felt comforted. She squeezed my shoulder, wished me luck, and wheeled me into surgery. When I awoke, I was told that I had adenocarcinoma in my right lung and in several chest nodes. In other words, advanced lung cancer. A few days later, I received a letter from Dr. Reich. "Remember me, your friendly anesthesiologist? I came by to see you this afternoon as my professional duty, but also to express my sadness in hearing about your diagnosis. Your door was closed and there seemed to be a lot of activity, so I decided not to disturb you. As I'm sure you know, we as physicians are taught not to become emotionally involved in our patients because then we'd be continually devastated. But I guess because we had such a nice interaction before your surgery and because your life was one which I could relate to so well, being Jewish, professional, renovating a house, sandwiches at Virginia's, etc., your situation really struck a chord in me. I was very impressed that during the fear and anxiety you were experiencing, you still maintained your composure, your sense of humour, and even thought to ask me when I was getting married. So anyway, as you told me, keeping your wife and son in mind will make you fight strong, and I know this to be true. I know that you have a very loving and supportive family who will help you through this as well. Best wishes, and maybe I'll run into you sometime at Virginia's." I'd not forgotten Dr. Reich, nor will I ever forget her willingness to cross the professional barrier, hold my hand, and write those words. During the period between the 2 chemotherapies, when I also received high-dose radiation twice a day, I came to know a most exceptional caregiver. The oncology outpatients nurse Mimi Bartholomew, an 8-year veteran who had experienced cancer in her own family. She was smart, upbeat, and compassionate. I had to receive fluids intravenously every day at the clinic, and while there, we talked regularly about life, cancer, marriage, and children. She too was willing to cross the professional Rubicon, to walk out and talk about my fear of dying, or even worse, my fear of my life, of not biking through the hills of Concord and Weston on summer weekends with my brother, of not seeing my child grow up, of not holding my wife in my arms. And she took the risk of talking about her own father's recent bout with cancer. I cannot emphasize enough how meaningful it was to me when caregivers revealed something about themselves that made a personal connection to my plight. It made me feel much less lonely. The rule books, I am sure, would frown on such intimate engagement between caregiver and patient, but maybe it's time to rewrite them. And when I contemplated not living to see my son grow up, or not cherishing my wife for a lifetime, I thought of King Lear, who at a low point wailed, "I am bound upon a wheel of fire, that mine own tears do scald like molten lead." Around the time of the CT scan, when I was feeling particularly dejected, I had an appointment with Mimi Bartholomew for an injection. She was running late, and as she approached me in the clinic waiting room, she looked harried. But as she got closer, she could see how unhappy I was, and she put her arm around me and directed me to a private room. I began to cry, and she intuitively responded, "You know, scan days are the worst, but whatever the results, we are not going to give up on you. We're going to fight with you and for you all the way." I hugged her and thanked her for hanging in there with me. If I've learned anything, it is that we never know when, how, or whom a serious illness will strike. If and when it does, each of us wants not simply the best possible care for our body, but for our whole being. I am still bound upon Leah's wheel of fire, but the love and devotion of my family and friends and the deep caring and engagement of my caregivers has been a tonic for my soul and has helped to take some of the sting from my scalding tears. Ken died a few months after his diagnosis. You can read the full version of that story if you just put Ken Schwartz and the Boston Globe into Google. It's a really emotional and powerful read. But out of sadness can come great hope. Ken Schwartz's wife, Ellen, now Cohen, and along with other family and friends, set up the Schwartz Centre for Compassionate Care at Massachusetts General Hospital. The mission of the Schwartz Centre is to promote compassionate care so that patients and their caregivers relate to one another in a way that provides hope, support and sustenance. The premise is that if we are better able to make personal connections with patients and colleagues, then we have a greater insight into their own responses and feelings. Basically, that if we're resourced, so will our patients. I can either talk into the microphone or see my slides, but I can't do both. So what's a Schwartz round? So a Schwartz round provides a structure where all staff, and it doesn't matter what they are, what background, clinical, non-clinical, can come together regularly to discuss the emotional and social aspects of working in healthcare. Holding the hand of somebody going for a termination of pregnancy who is homeless, holding the hand of someone who is crying because they're not going to see their child grow up, costs us too. And if we don't recognise that and deal with it, then we will slowly become damaged. So the purpose of the rounds is to explore that, to think about it, to talk about it. It's an opportunity to discuss and look at and unpick some of how that makes us feel. So the Schwartz Centre for Compassionate Care was founded in 1995, and then in 1997 they set up Schwartz Centre rounds initially in America. In 2009, the Schwartz rounds came to the UK. They were brought here under the auspices of the King's Fund and something called the Point of Care programme, which has now become the Point of Care Foundation. Rounds run generally starting off, they ran in big hospitals. They started off in two, the Royal Free and the Cheltenham and Gloucester, and they were there as a trial. And then slowly they spread out. South Devon, Torbay Hospital was one of the first in the second wave to take them on. Now they're running in educational settings as well. They run in universities, hospices, GP practices, all sorts of places now run them. They're a copyrighted process. You can't just run them yourself. You can't decide you're going to do it. You have to have a license. You have to be trained as a facilitator, and they run in a set way. And there are some differences between them and other fora that can be used to support people. And I've just put a slide up there that talks about some things that are similar and help, but aren't exactly what a Schwartz round is. They're not supervision. They're not a debriefing. They are loosely based on the structure of a medical grand round. And the thought of that was purposeful. Many people were familiar with the structure of a grand round. We knew what it looked like. You got together, often in a room such as this, to discuss a difficult clinical case. But the purpose of that grand round was to problem solve, was to come up with solutions. But we knew the structure of that. And so the idea was to use that structure, but for a very different outcome. So they're structured, they're confidential. We're going to have one shortly, and for the purposes of the Schwartz round that we're going to hold this afternoon, everybody who wants to come to it, whether you are currently in this room today with us or online, is going to be an honorary member of Plymouth University for an hour. And that's because the licence means that only people in that organisation can attend. So you're all honorary Plymouth University members for the purposes of the Schwartz round. It doesn't matter who or what you are, you're really, really welcome to come along. Interestingly enough, and for anybody who is out there and listening to us talk today, who is from a charitable background or is a patient or a service user, normally that particular group of people is excluded from Schwartz rounds, which sounds quite unusual. But in fact, the idea is that it would be quite inhibitive if patients were in the room with us, and might stop people being quite as open as they might otherwise, because they would look to protect the sensibilities and the hearts of the patients who were in the room with us. And sometimes we need to be a bit more basic in what we're talking about. So patients are normally excluded from this process, but today they're not. Some recent studies have shown the power of Schwartz rounds. They're a nice thing, but they're not just nice, they're impactful. And they show that those people who attend Schwartz rounds report that they are obviously popular with staff, but they result in better team working, decreases in perceived levels of stress, an increase in the ability to cope with psychosocial demands of care. And the more rounds you attend, the greater that becomes. And 85% of people who participated in rounds feel better able to care for patients. 85% people feel they can look after patients better because they've attended a round. They do start to impact on institutional culture, and they do result in a greater focus on patient care. And if I was asked why attend a round, I guess I'd say why not? There's nothing to lose, and potentially there is much to gain. What we do as healthcare staff is an amazing privilege, undeniably, but as with all privileges comes cost. There are challenges, and we're exposed to situations that are distressing, and we don't need to feel we have to deal with that alone. There's that incredible moment in many Schwartz rounds where you can see people think, what, they feel that too? And very powerfully, especially if you've got senior staff and you've got more junior or newer staff in the room who suddenly realise that these are universal feelings. It doesn't change because you've been around longer. Maybe you get better at dealing with it, but the impact is the same. We need to build cultures where support, understanding and kindness are hardwired into the systems. And that's not very evident sometimes, but Schwartz rounds can help. They're not the answer to everything, but they're a part of that. And the connections we build between ourselves and those we care for matter very much. And they have a demonstrable impact on patient care. We need to be daring, and we need to cross the Rubicon more often than we do to look after our patients. So we have a round that's going to start in a couple of minutes' time. For those of you in the room, there's no compulsion to be part of a Schwartz round. If it's not for you, you're really welcome to get up and leave. I'd really like you to come back in an hour, though, because we've got our final speaker, who's a service user, who's going to talk about compassionate care from her perspective. And we've got the closure of the conference. It'd be really nice if you came back, but you're very welcome to stay for the Schwartz round. For those online, I'm afraid we're going to ask you to do another little bit of jiggery pokery in that you have to leave the conference Zoom because it's a webinar, and we want you to join the Schwartz Zoom, which was on your invitation and is also now in the chat. The reason is this is a Zoom meeting, and that means you can interact with us. And in fact, there are 2 facilitators and 2 people who are going to share a story any moment. And you will be able to interact with the facilitators and with the panelists. So the way it works is people tell their story. We usually have a theme. And the theme for this particular Schwartz round, unsurprisingly, is compassion, the power for good, and the impact of absence. I have no idea what the stories are of our panelists, but 2 people have very kindly volunteered to share a story. The facilitators who are trained Schwartz round facilitators, been trained by the Point of Care Foundation, will then manage for the next 3/4 of an hour a chat. People can make comment on the chat in the Zoom. And if you want to, you can unmute yourself and open yourself up, and we will see you on the big screen, and you will see yourself, and you can interact with us and talk to the panelists. We haven't done a hybrid ever. And in fact, for the last 5 years, we've been online entirely at the University of Plymouth doing our Schwartz rounds online. We went online for COVID, and we realised because of our geography, we're a long and thin peninsula down here in the southwest, we got lots more buy-in when we kept it online. But because we're doing the conference today, we're actually doing this hybrid. So bear with us. We think it will be okay. But we are going to try and manage it with roving mics and all sorts of shenanigans. So I'm going to just allow a couple of minutes of time for a little bit of changing here. In that time, please leave the Zoom. go to the Schwartz round Zoom and log on to that. And I also make the same claim as I did to the people in the room. When the Schwartz round has finished, there's a short break. Sometimes just people need to just de-stress a little bit or just think or reflect. And then we'll come back for the final presentation, which is a service user. So I'd very much like you to be here to support them, and then the conference closure. So I'm going to hand over to my colleagues who are going to facilitate the Schwartz round.
Hello.
Hello.
Okay, so we're on to our last speaker, and really excited by this talk. And it's Lorena Hall, who will present a talk entitled Autism Through Our Eyes. And I think there's a real power to that perspective change. So I'm really looking forward to hearing about this. Lorena is a health and social care lecturer at Bishop Grove, I'm going to try and pronounce this, Bishop Grosseteste University, whose career spans more than 2 decades in health and social care. Her experience encompasses roles in community inclusion, patient experience with NHS England Leadership Academy, and service management in a national self-advocacy and adult autism services. Currently pursuing her PhD at the University of Lincoln, she focuses on health and social inequalities for people with learning disabilities, with particular emphasis on injustice and communication. As a leader reviewer, she works to improve care pathways by reviewing the lives and deaths of people with learning disabilities and autism. Her academic work is uniquely informed by both professional experience and personal insights, bringing authenticity and depth to her research and teaching. During the pandemic, she demonstrated her hands-on commitment by working in hospital wards and supporting vaccination efforts. Her presentation today draws on her remarkable breadth of experience in both the practical and academic contexts. So, Lorena, hopefully you're behind me, and very much welcome to you.
I'm here.
Hello.
Hello, thank you. Wow, what an introduction. So I will just very quickly share my slides. Right. So, wow. Hello, everyone. Thank you for that introduction. That was, I remember sending it off, and it's always eerie when we hear about ourselves. But yeah, you did say Bishop Grosseteste University quite correctly. Well done. It's never easy. I always cop out and say BGU. So thank you for that. So yes, I'm a health and social care lecturer here. I've had a very unusual, well, perhaps not so unusual nowadays, to be fair, when I think of some of our students. But I kind of fell into academia. So today I'm going to talk about the main reason behind that, and kind of tell you how I fell into PH study for my sins. I don't usually talk about my son's adult life. This is my son, Mikey. I don't usually talk about his adult life because it's not really my story to tell. But then I have I kind of think it's within best interest for healthcare education to be able to do so. And knowing him as well as I do, I kind of see it as Mikey's living legacy. I used to change his name, but I just end up calling him Mikey. Yeah, it's his, and yes, I'm sure. I should also point out that I myself am autistic, so if I pause for a second, it's just processing what I'm saying, so please don't think your screens are froze or otherwise. But I want to tell you a story about Mikey. He is now 24 years old. If you can see me on the screen, this is where you say you don't look old enough. And he has a mixture of diagnoses. He is also autistic. He has learning disability. He has cerebral palsy caused by connectorus at birth. He has Soto syndrome, kidney impairment, lung disease. Every medical student's absolute dream. They just love Googling, and I think that every doctor he's ever met thinks they're going to find some unique condition and name it after themselves. But to me and to anyone else who has the privilege of meeting him, and I'm sure to all of you, he is just Mikey. And I am the most luckiest person in the world because I'm his mum. It's an absolute privilege. So he now lives, just a bit of context, he now lives with a provider because I have this fear if something happens to me, I don't want it to be an emergency situation. And also it means I'm very involved in his care, and should anything happen to me, I'm not planning on it, just put that out there. Should anything happen to me, I know that he's in the best place that he can be within his situation. He is non-verbal, but sure does he make his needs known and his wants and wishes. And so, yeah, he lived with me till he was 18, and then it was a very careful planned transition to where he is now. So, as I said, I'm very involved in his care. And my own background was originally in animal care, and then I had Mikey, and that changed, absolutely changed everything. I was, well, if you're in a veterinary surgery and you're responsible for the anaesthetic of an animal, if my son had a seizure, the vet surgeon wasn't too pleased if I had to leave suddenly. Obviously his priority was the poor animal that he was operating on. So I did try to keep working after I had Mikey, but as I'm sure all of you know, it's you have a plethora of appointments and things especially when they're very little. But that eventually I was able to run an art business, because that's my thing, and it led to art for people with learning disabilities, workshops, research, this, that, and the other. So then going back to Mikey, he has a gastrostomy. He is able to eat orally, but due to dysphagia, it's safer for him to have particularly liquids and medicines. And to be fair, I can't blame him, because some of those medicines taste disgusting, through his gastrostomy. And what happened was, this was when he was an adult, living where he's at now. It came out, and the provider did not put a plug in to keep the stoma open. And some of you may know, if you don't keep the stoma open, it can start to heal within 20 minutes. Unfortunately, that happened for Mikey. I myself have changed many of his gastrostomies, but I wasn't close enough at the time to be able to go and do it. Plus, there's whole issues around insurances, and I won't get on my soapbox. So unfortunately, he had to go to the local hospital. They did try to, but it was a no-go. His stoma was quite healed. So it was decided, a very quick best interest decision, that he does need another stoma resiting, and the surgeon was not available until the next day. So that's okay. We could safely syringe medicines, and he could get his nutrition. So he was admitted to an adult ward. They did put him in a side room, so that was great. But by then he was starting to get stressed. He's got past experience of some trauma from hospital visits. And I said to them, he can't be operated on until tomorrow. The surgeon's not available. Please, can you let him go home with his carer? He'll get a good night's sleep. They'll bring him back at 3 o'clock in the morning if you need them to. Just let him go home and sleep. It will be much better for him. He's not medically unwell. And I will sit on that bed and stop every nurse that tries to take the bed. And they said, no, he's got to stay in hospital. So I grumbled a bit and thought, well, okay, well, no, he loves his iPad. So he had his iPad. It helps regulate him, and it helps him take him out of the anxiety bubble he finds himself in. Then it came sleeps time, and I said to them again, he's not unwell. He has his own Massimo SATS monitor because he's on oxygen overnight. Please don't come and do his obs. Let him sleep as much as he can, because historically, once he's awake, he is awake. I had many nights of him waking up at 1 in the morning, and that's it. He's like, hello, morning, let's get on with life. But so they said, okay, well, but then staff changeover. Sure enough, 12 o'clock, someone came to do his obs, thermometer in his ear. That's it. Bing, wide awake mics. So it was a very, very long night. All the time that this was happening, anyone that came in the room, I said to them, when he goes for his op, obviously I need to go with him. That is standard practice, thank goodness. But when he wakes up, I need to be in that room. Anyone who's had an anaesthetic know that when you come round, you can it's almost like you're still a little bit drunk, you don't know where you are, but you understand why you feel like that. For Mikey and many more like him, due to his understanding, he doesn't understand, and it's very, very scary. He's in a scary place with scary noises, scary lights, and all he needs to see is a friendly face, and that friendly face he's stuck with is mine, which seems to work. So anyone who came in the room, even the tea lady, who in my opinion in any hospital is the most important person because she always bought me a cup of tea. Anyone who came in the room, please, I need to be there when he wakes up. And I don't mean after he's awake, I mean as he wakes up. The first person he needs to see is me. So went down to theatre. He wasn't too impressed with leaving his because by then he got used to his room and he was happy thinking, wow, I'm getting on this iPad time. So I had to bribe. I signed, he uses his own version of Makaton. I signed that we were going, and then he would be able to have some food later once he'd had a little sleep. So he seemed quite happy with that. Went downstairs. He wriggled a bit for the mask, and no matter how old they are, when they do fall asleep, your heart, your mum heart, just it's a moment. But anyway. So left him in there, very capable hands, was asked to go back to the ward, so I did. And I think that most of you can probably guess what happened. I was sat waiting to get the call to go back up to him. And I got the call and they said, he's awake, he's distressed, you need to come here now. So I must have flown up there. I don't even remember going up there. I flew up there. I walked into the room. And he was perched on the edge of his trolley. He was so distressed, arms and legs everywhere. He was beyond the point of de-escalation. No dignity. He uses pads protection, whatever the right word is. So he was just in his pad. He was pulling at his new gastrostomy, his peg, and there is nothing more heartbreaking than seeing your child in a whirlwind of anxiety and not being able to cure it with a cuddle. But that's what I had to do. I had to go behind him, put my arms around him like bear hug, keep my head out of the way, because when he's stressed, he can extend, and his beautiful head does hurt when it makes contact. And hold his arm, and the staff who were slowly moving away because they just didn't know what to do. I had to hold his arm and say to them, he needs midazolam. I knew that was safe for him. That's his epilepsy rescue med, and it'd been used before when behaviour had got too much for him. So they gave him midazolam. So then he went into happy midazolam world, back on the ward, and he was okay, as okay can be. Obviously, they wanted the surgeon to come and check that he hadn't done any damage to the new gastrostomy in the stoma. And at that point, the children with adults with disability social worker called, because obviously we were having conversations about aftercare. And it's the first time in my life that I was speechless. I was given the phone and I could not speak. And I'm usually pretty good at that, as you can tell. But I was just speechless because it was so preventable. If they'd listened and I'd been in that room when he woke up, it would have been all prevented. The sister of the ward wanted him to stay because he'd had midazolam. The surgeon came to see him and he said, get this boy home before he's fully like back to how he should be, because he's been through enough. So we got him home while he was still half midazzled, and he recovered really, really well. What a trooper. So that's the sad side of it. And what happened after that was I wrote to the CEO. I wrote to the CEO and I said, I would really like to talk about what's happened. Please don't pass me on to PALS. You need to know what's happened in your hospital that you're responsible for. So to be fair to him, he did meet with me. And then I also met the director of nursing. And on the back of that, they then recruited for and appointed a safeguarding learning disability lady nurse, because they have LD nurses, but there's never enough, as we all know. And there is a positive to what happens when, after 18 months, when you have a gastrostomy, it needs to be changed to a mini button. So alarm bells, I was just so panicked, but the management for that was just incredible. We knew it was going to happen. The LD nurses were involved. Long story short, what happened on the day was he was admitted straight into theatre in the morning at 8:30, which helped because although he was quite annoyed that he'd not had any food, it wasn't a whole day of waiting without any food and him not understanding why. Straight onto the ward. He had a very tiny dose of midazolam before he went even into the anaesthetic room just to help settle him. And as I was talking to the anaesthetist and the surgeon, I told them my background within veterinary care, and they actually said, well, you can be in there when he's intubated. So I was in theatre when they extubated him, and definitely there when he woke up. And when he woke up, he was in paediatric recovery, although he's an adult. They kept it just for him, and he was home within the hour. It was just so, I mean, it wasn't easy. It's not, it's not nice for him to have another anaesthetic, but it needed to be done. And yeah, it was a totally different story because someone listened, and that's the absolute vital thing. And I have this saying, which is behind me, but I don't know if I've mirrored it right, so I've put it on the slides anyway. I see my son's legacy and our story as being the microphone and not the voice. All too often we hear with the voice of, and it's by well-meaning people. Obviously, self-advocates, it's a different matter, but those of us, I don't have a learning disability, but I see myself as being able to be a microphone for Mikey and many more Mikeys with them. And yeah, I think that's always the message that I would like people to take home. We can only be people's voices with the microphone. And so I said that I would just briefly say how it led to the PhD. My PhD was initially, and it was on the back of the conversation with the director of nursing, because I felt that I was becoming known as a neurotic mum. That mum where when I ring up, they probably throw the phone around saying, I'm not talking to her, you talk to her. I've been on the other side of the door. I know how it can sometimes work in some places. And I really felt that anything I tried to make wouldn't be happening because I was seen as that person. And so it led me to think like, well, what can I do? I did my master's in art and social practice. So that was using art as therapy, not art therapy. And I actually quite enjoyed the researchy side, surprised me. And from there it led to, I thought, well, if I want to make a difference, then perhaps I can do it through some research. So originally it was on the back of what happened with Mikey and a few other bits and bobs, looking at health inequalities in acute care, but NHS ethics was a little bit rough because for me it's important that people who don't have capacity to consent are included in research, and so it's now it's social care research inequalities, and also looking at actual research and how we do research inclusively and including people that philosophy is about, because it's one we'd like to include people in the research in gathering of the data, but actually in analysing it, I think that's important because my brain will analyse things differently to the people who are living those lives. So that's now what it is, and it is getting across that, being the microphone and not the voice. So it's very exciting, and I could talk about my PhD for quite a while. And I fell into academia teaching because started off as me saying I'm because I'm self-funded PhD student. Is there any teaching? And I was given some teaching and I absolutely fell in love with it. So now I've got a post as a lecturer in health and social care. And yeah, I absolutely love what I do. But most importantly, the young man you see on the screen, that's the reason. He keeps me grounded, and it's an absolute privilege to share our story and what happened with him with you guys today. And just to, yeah, I think it's compassion in healthcare obviously is absolute paramount, but it's the real stories where we can see it working. And I think that's what's important. So yes, that's me. I'm happy to take any questions or comments.
Great. Thank you. Can I just say it's our privilege to hear your story, because I think it's an incredible way to finish what's been an amazing day. But as you say, the genuine stories and how that powers everything that we do and what we learn from those. It's quite amazing, isn't it? Could I open up to any questions? Because we have a few minutes, actually. So are there any questions either in the room or virtually?
There's always a bit of a delay from the online ones because it's the webinar. They've got to use the Slido, so that does seem to be meaning we're getting the questions for the one before the last one. It's a bit like that to Ronnie's sketch, I'm afraid. the question from the question beforehand, but Lorena, I was listening with great interest as a nurse of many years. I also listened with some degree of frustration that rules and regulations always seem to take precedent over common sense. And that thing about you very gently alluded to the frustration about insurance and not being able to replace the button yourself and so on. And I wonder if that's part of one of the things we ought to be looking at when we are teaching healthcare professionals, that guidelines are there to guide, they're not there to dictate, that there's no guideline or policy or procedure that can work 100% of the time for 100% of people. And therefore we need to be brave and we need to be courageous and challenge where things aren't working for people rather than trying to make the person fit into the guideline. We have to adapt the guideline to fit the person. And why we can't send somebody home. I know we're desperate for beds. I know the hysteria around the preciousness of a bed, but why we can't do what's best for the patient and still get to the end objective. So maybe that's something we ought to be teaching. And now as a lecturer in your own right, do you think that's something we can teach?
Yeah, I think so. And I'm fortunate that I've got these stories that can demonstrate that really well. Because as you say, if I'd been able to go and replace that or put a stopper in just to keep that stoma open, then it would have negated a lot. And as we know, for some, it comes down to economics, but we've got to be realistic as well. I think the blinkers are all too often on. And yeah, it's a delicate balance really, because we do live in a world where we're scared of litigation. And certainly for the provider, they would be worried about, oh, well, if mum did it. And I can say, oh, I'll take the rap as much as they like. They can go through safeguarding whatever they need to do. My priority is Mikey and what's right for him and making that very quick best interest decision. But I also get that we're all trying to cover our own backside. It's delicate and it's hard, and it's hard. I feel for the students because I think that it's right that we don't put the rose tinted glasses on, but equally it's hard not to make people think, oh well, actually I don't want to do that, that's too much risk. We can't be risk averse. It's delicate.
Lorena, there is a question that's just come in from Wendy. What advice do you have for other parents and family members?
Well, I mean, it goes without saying that most people will speak up for their person by whatever means. And sadly, sometimes you do have to play the game a bit. But yeah, just never ever worry, and that I need to tell myself this, never ever worry about thinking, oh, people think you're that neurotic parent. Because who else is out there being that neurotic parent for that person? That person needs you to be. If you don't, then that evening You know, it'll play on your mind, you won't sleep. That professional may or may not. I'm sure there's many compassionate, but it's their work. They have learned to compartmentalize and leave that at work, and that decision at work, that thought at work, that staff room gossip at work, whatever. Whereas this is their lives and their person's lives, their children, be they adults or kids. We've got to keep being the microphone, because otherwise voices really don't get heard. And as professionals, it's helping people feel safe to do that. And that's something that can't be taught from a textbook. That comes with experience and just learning about people, I feel.
Yeah, it's, as an older nurse now, talking to our students, some of which are out in our audience today, I think I want them to get to the end of their training with enough courage to challenge. I don't really care whether they can put a cannula in or not. It's of no interest to me at all.
Yeah.
And many of them won't even use that skill, depending on where they go and work. What I care about is whether they can hold complexity, whether they can make common sense decisions and stand and have the language and the confidence to defend things, and to stand with a mum who is a neurotic mum or not, it doesn't matter, and stand next to them and advocate for them and come up with common sense plans and make the system work for each individual instead of trying to make the individual fit the system.
Yeah. And
I think that's a huge skill. And I do think it's something we should be teaching. And I think your story is one of the ways that we can teach that sort of thing. So I'm enormously grateful that you've been, and grateful to Mikey as well for being present with us today, even though I'm sure your knowledge of him knows that he has consented in his own sweet way to be here. And I'm sure he's been incredibly impactful as well today in your story. Unless there are any more comments, there's a lot of comments in the chat about people just thanking you for sharing. There's another one there from Simone. I don't know if you've noticed it.
Why do we get it so right as well as so wrong?
I just wonder, why do we get it so right as well as so wrong? So obviously there's experience of all of the stories today have been some very positive stories of when in fact this has been a very positive conference, and that's wonderful, because as you say, there are an awful lot of compassionate people out there.
Yeah.
But I think the implications of when there is a lack of compassion and common sense or holism, and it's an overused word, but it's an important word, it goes badly wrong, doesn't it? Mikey had an unnecessary operation that he didn't really need, a traumatic stay in hospital, which will affect his next visit to hospital as well. So I think that's a really important thing. We need to remember, no matter how old someone is, you know your child better than anyone. And I think that's really important. Our family members, those we love, we're their person. I think you used that lovely term. We're their person, and we need to be listened to and heard, and accommodated in the care of the person. And I think that's a really good final point to leave on. And you've had some nice praise for your bravery and your commitment to your son, but also to sharing your story. And I will remember to be a microphone, someone said. And someone else has said, well done for pushing the CEO for the meeting, and what courage you have. So hopefully, although I'm sure it's been quite a challenge to share the story, because each time it takes something from you, I'm sure, but hopefully it's put more than that back. So thank you very much.
No, thank you for having me. Thank you.
And on that rather positive and inspiring note, I think we're at the point where we can wrap up the conference. So I'm going to hand over to Nick to start that process.
Well, it's been, as always, a really rich day, and I've just tried to summarise some of my thoughts and my takeaways. And thank you to Sarah and the team for putting this on. It's been really fabulous, hasn't it? I think we've heard and seen how collective action and small gestures can create profound ripples of change. Professor Michael West emphasised that emotional impact on our daily interactions extends through at least 3 degrees of separation. Whether it's asking a colleague, how can I help, as Alison Sykes reminded us, or crossing that professional boundary to hold a patient's hand, which you discussed when we're talking about Schwartz round. These seemingly small actions actually carry immense weight. A reoccurring theme throughout discussions today has been the vital connection between staff well-being and patient care. Helen's exploration of compassion satisfaction versus compassion fatigue in emergency departments highlighted how system pressures can impact our ability to deliver the care we aspire to provide. As Caroline pointed out, this understanding is important for workforce retention and creating sustainable healthcare systems. We're also deeply explored the importance of inclusivity and respect in healthcare. Maaya's presentation on anti-racism and health education reminds us that compassionate care must be accessible and inclusive to all. That was beautifully complemented by Serina's work with the vulnerable populations, showing how we can extend our reach beyond traditional healthcare settings and how being human and respectful is the foundation for what is a good interaction. Again, the power of storytelling and reflection has been another key theme for me today. Through the Schwartz rounds and the personal narrative shared, we've seen how stories shape our understanding and our practice of compassionate care. And as Lorena has just told her story, the importance and duty we have to listen to those that we care for will transform our perspective and approach. Be the microphone, not the voice. Be someone's person. My takeaway today, compassion is not an infinite resource to be rationed, but rather a renewable energy that grows stronger when we nurture it collectively. It needs to be protected, facilitated, and practiced in our leadership, in our teams, and in our daily interactions. And the evidence is clear. Compassionate healthcare isn't just about being kind. It's about creating environments where both staff and patients can thrive, where our teams feel empowered, and where everyone feels valued and respected. And as we return to our roles, let's remember that each of us has that power to be part of this positive change, one small action at a time.
Thank you, Nick. Tosin's also come up with her reflections on the day. So I'm going to hand over to her.
Yeah, thank you. It's been a great pleasure to participate in this 5th conference, particularly as a panel member and for the first time anyway. So I would like to thank everyone, including the research team, for making this conference a success. Promoting the concept of compassion is an integral part of healthcare to improve patient care and staff experience. And I believe this should be everyone's business in healthcare settings. Again, this conference, through numerous presentations, have proved that. For example, when Dr. Tobin was talking during her opening speech, she said, compassion is not just human, however, clinically imperative, which also linked to Helen's conversation, where she coincidentally described her findings on the explorative mixed method study, particularly her final thought, where she said compassion is not a commodity, but an attribute which needs to be facilitated and nurtured for us and again for our patient. Professor West, during his conversation with us, he said, when he was trying to give us a kind of importance of collective, inclusive, and collective leadership at individual, organization, and national and global level, majorly to improve the patient and financial outcomes in healthcare settings. One key thing that I was able to hold on to is when he said leadership is not inclusive. It's not, if leadership is not inclusive, it is not compassionate, and vice versa. So Dr. Sky shared her honest experience and reflection on compassionate leadership again, just like the way Professor West talked about that. So she highlighted that some of the activities that she embarked on during her own time, lighting her loads. Maaya and Caroline, they spoke more about the fantastic teaching and their research approach model for their students, which appears to be an added value to compassionate education. Dr. Paquita and our dear Serina, they talk very much on human values in healthcare forum. And again, especially the Sarah story described by Serina, where interpersonal approach can make a meaningful difference, especially among the most vulnerable in our community. Dr. Tobin again, and the group, the SWAT round, where the workforce, irrespective of their background, discuss how they feel in a confidential and compassionate manner. And lastly, listening to Mickey's story through Lorena that prompted positive action within the service. Compassionate in healthcare is paramount. That's what she said. And again, be the microphone, not the voice. I have a question for everyone, which I want us to take home. Without the stresses of today's in healthcare system threatening the delivery of compassionate care, the question is, how do we navigate this? Thank you.
Thank you, Tosin.
Yeah.
I'd like to thank both Tosin and Riya. They are here because they won a competition. We put out a competition for students. This is a conference for the collaboration of compassion in healthcare education, and we were really mindful of hearing the voices of those we educate to tell us what they need and want from us. And one of the things we wanted to do is make sure students were present on the panel. So we asked students to pitch for their place, and both Riya and Tosin wrote incredibly eloquent, meaningful, and very touching reasons why they wanted to be engaged in today's conference. So I'm going to finish up. Michael said this morning that compassion provides hope in the dark, that we as a healthcare community are the largest workforce in this country, and we touch everybody's lives and are touched by our colleagues. Most of us who work in the system are also, as many people have described today, we're also users of this system. We just basically work in the same community. Sometimes we need it to help us, sometimes we help it. And Michael said that the way we can do that best and to provide hope in the dark is to do that by providing compassion. So I hope very much that the conference has been useful. This is our 5th one. I hope there'll be a 6th one. Maybe not next year, but certainly the year after, if not. So we'll keep going. It's been an absolute delight to listen to all our presenters today, and I think you'll agree that people have given their time for no money at all passes hands. That's why we keep this free to attend as well. So people are living the values they're espousing. We'd also be really, really grateful if you could give us some very simple feedback. We've got a very simple survey, which we're going to pop into the chat now. So if you do have a minute, could you please fill that out for us? When we finish, we'll keep the link open to give you time to fill it out. It will just come back up to the screen with the slide. We really value any thoughts, ideas, people who might want to volunteer to speak at the next conference or to come and be on the panel. And any ideas about how we can improve this and keep it going. And the last thing I'd like to say is we're midway through December, so whatever you're doing through the holiday season, I hope it's enjoyable. I hope you have some rest and time to recuperate and to look after yourself and practice some self-compassion. And I wish you health and peace and happiness for the holiday season. Thank you very much.